This is, yes, that's how I am, right? Okay. Was that what she said? She chose to be an artist, and her son, and I was. Oh, yeah, that's what she was.
Yeah, she said that's exactly right.
Yeah, I thought her. I remember the head, but you're not. Already approved it, so yeah, I'll get it. Okay, everybody ready to share? Okay, welcome everybody. We will get started with the board of education portion of the meeting tonight. So Teresa, are you handling this tonight? Hello, there you go.
Oh, wait, oh.
Screen.
No. Here, take a one.
Right.
250.
Yeah.
It's not on, actually, I don't know why it's on there, but you can, so click once to make sure.
I just minimize it.
You can't see it over here.
Okay.
Okay, are we good to go?
I think we are.
Okay, we are going to learn about revenue cycle management tonight. I'll turn it over to you, Teresa. Okay, yep.
So Rex has a slide that's going to show us each portion of the revenue cycle. And then what I want to do is be able to just high level speak to each section of the revenue cycle. Just to show you how complex it is. You know, a lot of people think it's, you know, the patient comes in, they're treated, they're billed, everything's done. And it's just not quite that easy. So we wanted to demonstrate for you the full revenue cycle. So starting with the insurance credentialing. This step in the revenue cycle ensures that the hospital and the doctors are approved by the insurance companies to provide services that we're going to get paid for. And so this involves verifying credentials, keeping insurance panels up to date, contracts up to date. And if it's not done correctly, providers aren't properly credentialed, insurances won't pay for the services that we're providing. And that leads to denied claims and lost revenue. So very important step of the revenue cycle. Then we get into our pre-registration and patient registration section. This is the gateway into your revenue cycle when patients present to the hospital, either by making appointments or showing up for procedures, walk-ins, emergency room services. And so it's very important that we capture all of the demographics accurately. Along with patient's insurance information, that we sequence the patient's insurance information correctly so that we're billing the proper primary and secondary or even tertiary insurances. And if this process isn't done right, then we have patients who don't get their statements, they go to the wrong address. We have claims that go to the wrong insurance company and we get denials. So that's delaying our claims processing and cash and revenue for the hospital. So another very important part of the revenue cycle. Then we have our patient encounter. When the patient comes in for their treatment, they're seeing the doctors and the nurses. It's very important that the doctors and the nurses record the services that they're providing to the patient and that they're giving us enough documentation to charge for the services that they're doing. So it's very important that they do that. This information helps us figure out what charges support the services that they provided in that treatment. And again, if this process is done wrong, we miss charging for some of the care that was given. That means losing money to the facility. It could also cause problems because of very strict billing guidelines with some of our payers. If we don't have procedures that support the diagnosis that the patient is coming in for, the claims will deny. So documentation is very, very important as well. The next section that I have here to show you is the charge entry. Here we turn the care that the patients get into the charges that we bill. And here we don't want to miss anything or make any mistakes that are going to lose money or revenue for the facility. So if anything goes wrong in this area of the revenue cycle with mischarges, of course, we get rejected bills, which results in lower income to the hospital. Then we get into claim. Do you guys have a picture that's closer to you, or are you looking up here too? Okay. Next one is claim submission. This is when we send the bills to either the patients or the patient's insurance companies. This portion of the revenue cycle is very important because we want to be sure we get it to the right insurance plan in the right format that they require. Many of your payers have different requirements of those formats, and so we have to stay abreast of what those are so that our claims aren't denied or delayed and that the patients aren't receiving bills unnecessarily as well. The next section is our accounts follow-up section. And this is where after we send out the bill, we're following up with the insurance companies to make sure they receive the claim, that they are processing the claim, and that there's no reason that they would deny the claim. We try to stay ahead of that so that we can have our claims adjudicated as quickly as 30 to 45 days with most of our payers. That's just the time that they take. Our quickest payer is Medicare. Medicare has a 14-day turnaround. So this helps us by doing the follow-up, this helps ensure that we get the money for the services that we billed for. So if we don't do the follow-up, if the claims go unpaid, or if there's a root cause or an issue going on that we're not aware of, that's slipping under our radar because we didn't do the follow-up, that causes issues as well. So we're able to head off a lot of things by keeping current with that follow-up. The next step here is patient statements and payment processing. So when the patient's out-of-pocket responsibility is determined, we send a bill to the patient. And we want to make this very easy for the patients to understand and give them a way to pay their bill, either through my chart or calling the billing department, or even reaching out to us seeking financial assistance if they're unable to pay. And if this portion of the revenue cycle isn't working right, the patients get confused. It delays with the patient payment. It hurts our revenue, and it also hurts our community, I think, too. It puts a burden on the community. And the next section, denials management. Sometimes insurance companies say no, they're not going to pay the bill. And we find out why, and we either fix it or we appeal their decision to not pay the bill based on our experience or contract language. And we fight them on behalf of the patient to get that claim paid. We don't just take no for an answer. So, and in this section, if we're not staying current on our denial management, of course, that's loss of payments to the facility and a lot of extra time spent in fixing problems. Another very important step. Next, we have reporting and performance improvement. So we like to do a lot of root cause when we find an issue. We get down to the root cause of the issue, we quantify it, we find out, if it happened to one person, it likely has happened to others. And so we like to address it more holistically instead of just one-off putting out fires. And so using that data and that reporting to see how well our revenue cycle is working and where we can improve it in any step that you see there. So another important section, revenue cycle. So it is a big puzzle. It can be very confusing. It's not as easy as some people think it is. All pieces have to be firing correctly. Our aim is for the patients to come in, be treated, have their services and a clean claim go out, and the revenue come into the facility for those services, and then, of course, we're billing patients for their out-of-pocket responsibility correctly. Where we measure that, or we're going to be measuring that, so that we have a benchmark and can improve upon that. And you'll see a little bit of that in a few slides forward. Okay, so I think
Next
go to the next one. Which one we have our key performance indicators. So here, we've got people that are listening, aren't right? Okay. Go ahead. We're gonna, I've created a template that I think both Jeff and Rex enjoyed, where we'll be able to share some basic key performance indicators with you guys to show how we're tracking and trending over a period of time. I've taken it back to August when you built the hospital and opened the doors. There's no data here yet. We're in the process of doing that, but I wanted to at least share with you some of the information that we'll be sharing with you directly. A lot of the benchmarks that we're going up against here are HFMA benchmarks, so they're industry benchmarks. They're not ones that we come up with ourselves. So, but we will compare ourselves to those benchmarks. We'll be tracking cash, we'll be tracking DNFB, we'll be tracking clean claim rates, and average daily revenue. So that's.
Do you guys, you know what DNFB is?
Discharge not final bill. So that's any of the charges that when the patient's discharged, but the bill has not gone out, we are able to quantify what those charges are and why they're held up and the claim's not going out. Is it because it's a coding issue? Is it because a CDM, charge description master issue? There's many reasons why it might not drop. And so it holds on that DNFB, discharge not final bill. And we don't want that to be large. We want that to be very minimal. So we'll be tracking that and sharing that with you, as well as in what categories make up that DNFB number, in what section of the revenue cycle is impacting that, and what percentage in dollars. Because that allows us to be able to focus strategically on those areas and help them either resources or, find out what's going on. Next slide. And here again, tracking the DNFB against HFMA best practice benchmarks. We want to show you month over month how we're comparing to that. And so we'll be able to show you this on this slide that you'll be getting. And the next one is my favorite, cash. Our cash performance. So here we're going to be showing you month over month our cash performance. Both out of the legacy and the current system, and how we're tracking, how we've been able to reduce the legacy AR. You'll be able to see that tracking over time. And next slide. Rex might have to help me with this one because I can't see it.
I think we'll make sure next time you have handouts so you can follow along. But basically this, Michelle put this together and we've been tracking, cash receipts every day. This goes back a little further to compare month to where we're at. And if you could see it, you could see we're making progress. And I think we talked maybe last meeting about what do we need per day to cover expenses? And with depreciation still in the equation, even though that's a non-cash expense, we need about $115,000 a day to cover everything. 98, I think, if we pull depreciation out. But we've at least through the I think through the 19th, we were averaging right at almost 115. So we're about where we need to be, and they're checking now. I mean, we can talk a little bit more about how this all works, but being able to tap into Noridian and seeing what's hanging out there that we know will be coming the week of, so we can do better job cash projection forecasting. And I would say probably when you say that, probably the big things for the board to consider would be, and to pay attention, is the DNFB number, because that's, nothing happens until you get the claim out the door. Probably we have late charges, which will slow things down a lot. And then clean claim rates. I mean, and our clean claim rate should be, I mean, the industry standard is what,
Greater than 75%.
how much?
75.
So our 75% of our claims should go out clean the first
Yeah.
time. And we were running well below that. We're making progress, but we'll send this. I know a couple other boards I've worked with like seeing it until we kind of get on the other side of some of this stuff. So, but it's kind of fun to follow too, get it every day and kind of see where we're at and how we did the day before and how we're tracking to trends. So.
And just kind of to elaborate on what a clean claim is. So that's a claim that will drop on we have a 3-day hold on claims. That allows all of the charges to come in, the coding to be done. The claim will drop on the 3rd day. The claim will then be transmitted to the payer. If it doesn't hit any edits, it gets to the payer and they start processing and adjudicate it and we receive payment. So there's no touch along the way. That would be considered a clean claim. So that's what we're striving for is that industry benchmark of greater than 75% accuracy in that.
I mean, because every time somebody has to touch it or do it over, it's inefficient. Plus, sometimes I know in one place, people were shoving claims in a drawer back in the old paper days, and so we were even sending them out. So, but anything else you want to add about things they should kind of look at or?
We are going to bring to you at the next board meeting, we want to bring to you some vendors that we're looking at for both bad debt and early out. And so we want to bring that to you either at next month's meeting or special session, whatever you feel is more appropriate. And then also a proposal to do I call it an AR blitz, but an opportunity for the patients in our legacy system that have really old aged accounts to be able to pay them off at a reduced amount so that we can get them off of our books. And get the focus on our current AR. So these are some things that we'll be bringing to you next month as well. Any questions or concerns? Anything you're experiencing as a patient in this cycle, this revenue cycle? That you
It's really interesting. I have to be digging in a little more in depth.
Yeah, and I think the intent is at future meetings to kind of take a section now and kind of dig in a little bit deeper and focus a little bit more and give you some more in-depth background to that section. But we didn't want to give it all to you at one shot. So this was kind of the 30,000 foot level of the revenue cycle.
I know Teresa wouldn't want to bring this up, but she's only missing one certification in revenue cycles.
From the cost report, yeah.
It's easy.
It might be for you.
I do have one question.
Yes,
Are we using AI at all in our revenue cycle?
we are not.
Okay.
I was kind of wondering the same thing, like with the information that we get from the providers, like, are we efficient in that area of the whole cycle?
What do you mean the information
Well,
we
then-
get, like documentation?
Yes, so for the coding to be done properly.
There are some opportunities there, and I know we don't, in your organization, you don't have a clinical documentation improvement position, but we do get feedback from our coding department or coding vendor that we then provide back to the providers. We could probably do a better job at it as we find opportunities, no doubt.
Well, kind of back to Ashley's question, we were made aware of AI being used in that scenario, and it was kind of interesting. But wow, that's something maybe would be worth investigating.
Yeah.
And what I recall kind of specifically in a presentation from Health Tech was that it will look for things like, okay, if you have these codes, it's usually accompanied by these ones. And, potentially missed revenue there that we might not be getting, as well as helping with the insurance processing.
And some of our editors do that to an extent, but I wouldn't call it AI.
Mhm.
Those are just scrubbing systems. There are, I don't know if Epic has any opportunity for AI within their EMR. I don't know, but it definitely would be something to look into.
Yeah, and you've had your hands full and hit the ground running, but Ocean does have a product, and I understand it's better than your old employer's product. So that was part of the conversation. We'll talk later about our kind of our ocean conversation with their senior leadership team, but I know some of our providers are aware of it and they're excited to possibly use it as well. So we were just trying to get the rest of our stuff fixed, but that definitely is the
One
future.
step at a time.
Absolutely. Get the couch so we can afford all those things. Yeah.
So I can just speak very quickly with regards to the AI piece. We are already using AI for some of our hospitals. And I think that probably the best thing for me to do is to invite Derek to a future meeting so that he can present how we are using AI currently. The reason why we haven't started doing this with Sublette yet, or even had the discussion, is because there's just been so much to clean up first. We just, we really need, and we've really needed, FTEs and people to be doing it, because each situation is rather unique. So we haven't had the beauty of having, mass or large quantities of denials that we can actually just place into one bucket, because so many of them have just had different problems. So I'd be very happy to ask Derek to do a presentation. I know that possibly Ashley and Taylor might have experienced that at our last conference. We presented AI and our product, which is called Bob. But I'd be very happy to ask Derek to join and show you what we are currently doing.
Thanks, Tom.
And then also, the Sublette leadership team meets with health tech. We were meeting on a weekly basis, and what here is just an example of our task list of issues that we were tracking to. We've now kind of dialed that back to a bi-weekly meeting, but we continue to meet and collaborate and talk through some of the issues that the hospital is still facing and moving into resolution from week to week as we meet. So
It's a collaborative effort with health tech, our team, and then there is accountability built into this thing too, because I showed up a couple times without my task. No one said much, but you felt really bad. So.
yeah. So we just wanted to let you know that that was occurring, and this is just a sample of one of those.
And this is just the revenue cycle piece. We have finance, we have 4 other categories, I think. And you've taken over responsibility to do it, leading it, so we appreciate that.
I think we've come to the end of our education session for revenue cycle. Any other questions?
This has been the big focus, though, at least in the 2 months I've been here. I mean, and certainly it's been a health tech focus, and we're fortunate Teresa was available, but we're making progress. There's just a lot of pieces to it, but we're starting to see progress, and I think things will start spinning a lot more freely. Jeff has a lot of experience in revenue cycle too, so I think just hearing the 2 of them, and I left the conference room because it was way above my head and I was getting a headache, but they were talking about a lot of things that they could work on together. So I think I think by next month we'll see even more progress.
Yeah, it's good to see.
And any feedback that you have, please reach out. I'm always available, so love to get any feedback you have outside of this setting as well.
Well, the aspirational goal, just going around town, people would like our bills to be simple, out on time, and that's a challenge every place I've been. So hopefully this is the place we achieve that aspirational goal of bills that people understand and they're out timely. So that would be, I think, what people would expect. So
Yeah, we are, I'm actively working on updating the statement messaging that goes along with some of that information. So you'll see a change in that within the next month.
Well, it feels like we're making progress, so thank you.
Oh, yeah.
It feels really good.
Thank you.
Thank you for your work, all of you. In that area. Thank you for some of you. Break. Okay.
Stop sharing your screen.
question.
Oh, no. Never mind. This is new to me too. I'm still trying to figure it out.
Yes. I just was looking at these.
Oh, you-
They moved
I
up.
heard this wrong.
And then there's anything else. I'll see you. I don't want to say it.
This is Kirby from Senior Life Solutions. Tanya.
No, I got it.
This chair, treasurer, vice chair. Me too. So you came all the way from. Was it Iowa?
Oh, wow.
Yeah.
Wow, just to present tonight to us.
Oh, yeah. Coming on Tuesday, so I fly back Saturday. Go Monday, because I got the board.
We saw that they've got a nice little seat option.
Yeah.
Great, I want to present to them as well.
Yeah, breeze.
Very good.
Yeah. I
Got
got
nice brings one to heaven.
So,
So in that direction.
it's a beautiful area.
You know, so I'm gonna have to. She was talking today about. Where's on the light?
Tourism has gotten so overwhelming in some of these areas. We're up near Drake, some
I know.
Victor.
It's a dance, isn't it?
Yeah, we're up at.
We got Lisa's, we got.
Jackson, San Francisco, Target. Yeah, I think that I played that several, like people used to write little treasures.
So she is gonna get back to Pinedale. She wants to go to some like shops and hotels and. Yeah.
Six P M, I'd like to call this meeting to order. First thing I would like to do is ask you to join us in the Pledge of Allegiance, please.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Welcome to everyone who's joining us this evening. It's Wednesday, June 24th. This is our regularly scheduled monthly meeting. So we're happy to have everyone who's here. First item on the agenda is to set the agenda, but before doing so, I need to pull item E under new business, the TEA grant. That was previously handled and does not need any action this evening, so we'll remove that. Otherwise, to my knowledge, the agenda is correct and ready to go. Are there any additions, changes, questions? Concerns? Jan, I think we captured all the changes that were made yesterday.
I hope so, yeah.
Okay, there's Rex. Rex, are there any other changes to the agenda as it sits tonight,
So the,
minus the TBA grant?
that TA grant.
Okay. I will ask for a motion to set the agenda then, please.
Madam Chair, I would move to set the agenda with the rules of under new business.
Okay, thank you, Brenda. We have a motion. Charles, second. Second, thank you. Any other comments from the board? All right, all in favor of the motion to set the agenda with that one removal, please say aye. Aye. Any opposed? I guess I need a vote too tonight, so aye. Motion carries. Struck me after. All right, the next item of business on the agenda is consent agenda, and we have several items this evening to include 3 different policies, reviews of 3 different policies, and meeting minutes for June 22nd meeting, June 27th meeting, and June 3rd meeting. So, has everyone had an opportunity to review those documents and policies? Okay. Work for action.
Can I ask one quick question, of course, on policy? For the physician assistant and nurse practitioner responsibilities, I just had one quick question. It says participate with a doctor of medicine and a periodic review of the patient's health records. So are all of our clinical providers reviewing health records with MDs as well as like our ER or?
I don't think I understood your question.
Okay, so it's, as part of the policy, it says that they are to participate with a doctor of medicine in a periodic review of the patient's health records. And so I was just curious if all of our clinical PAs are reviewing records with an MD on a regular basis.
Not that I know of.
Okay.
I guess I'd have to look at the policy.
Okay, I just was, that was kind of new to me too, and I was curious how that was logistically done or what that meant for us. Maybe that's only in terms of the hospital. Doesn't say that, but
Does that have anything to do with the provision of oversight for mid-level?
No.
Okay.
It's just an annual review, like it's one that's already been in
Oh,
place.
so
You just have to
that's
review
very
it.
good.
Yeah, that's why it says scheduled review on it. Not necessarily annual, but they have to
Okay.
do it for survey. They have to be reviewed so many every, yeah.
Gotcha.
Some of them are annually, some of them are semi-annual. Yeah, so
As I was reading it, it was.
it's not
kind
a
of
ch-
thought,
Yeah.
just a question that I had.
Okay.
No, it's okay. We can table that one and bring it back next time.
You want to look into it, Doc, and
Yeah,
come back to
I mean,
us with more
my
information?
understanding, this applies to the hospital side. It's not the clinical side, but that was pretty new.
Okay. All right. Would the board like to pull that one pending further review or?
Yes, if that's okay.
Jen, to make a motion?
Sure, I would make a motion to approve the first 2 policies, financial planning and budgeting, management of contract services, as well as the meeting minutes from May 22nd, May 27th, and June 3rd, including any executive session minutes and to table the physician assistant and nurse practitioner responsibilities policy for the next meeting.
Okay, we have a motion, basically to approve consent agenda minus the physician assistant and nurse practitioner responsibilities then,
Yes.
policy. Okay. A second, and a second. Is there any further discussion, question, comment? All right, I'll ask for a vote then. All in favor of the motion as stated, please signify by saying aye. Aye. You approved. Motion carries. All right, next item on the agenda is public comment. So I'll open the floor up for anyone who has wish to make comment at this time. Everyone's so quiet. Is there,
I will share with me.
please, Lorraine.
Actually, I just told us this, but I think it'd be good for everybody to know. I have had several staff people from the Heritage Home comment to me over various weeks. And they have all, and some of these people were people that were resistant to moving the Sublette banner and the whole idea. And they have made really positive comments about Rex and his making them feel very welcome. As the first CEO that has ever really showed interest and stopping by. And yeah, I've been really taken back by as many that has commented about that. And of course, I wanted to let him know, but actually I think it's good to just tell you that was so heartwarming to me, to hear that, and especially from some that have been somewhat unsure of how it was all going to come together. So I just wanted to let you know. Thank
That
you.
is so nice. I'll be at the very end. Thank you so much.
Thank you for sharing, Lorraine. Always good to hear some positives. So,
Yeah.
anyone else have any comments, thoughts to share? Questions? Okay, is there anyone on the Teams, Jen, that I can't see anyone? I can't see if someone's raising their hand now. So.
No.
Nope. Okay. All right, well, seeing none there, we will move on. Next item on the agenda is committee reports, and building committee is first up, and I'd like to take this opportunity to let everyone know that the building committee sits at the moment in peace and quiet. We have a fully operating functional hospital. Our loan was closed and finalized as of June 15th with USDA. Our bonds paid at maturity. We're thrilled. I'm thrilled to report that we do have a few warranty issues that we continue to work through with the contractor. But aside from that, we are finished with construction. So until the next project, we sit. So that's good news. It is good news. Such good news. Tommy's finally sleeping. So. Any questions from anyone about that?
Well, you know, and it wasn't just a given it was going to happen either. I mean, about 2 weeks ago, it would, looked 50-50. So the amount of correspondence back and forth and phone calls and emails that Tanya was involved in and Lena and Michelle was incredible. So thanks for all you did to make it happen, because it wasn't a given.
Yeah, it was pretty sketchy for a while, so. Just glad it's behind us. Okay, if there aren't any questions, we will move on. Other business. Next item on the agenda is Sublette County Health Foundation. Carrie. Thanks.
We are also at rest, which is great for a minute. It's really good. We have 1.2 million left in the money market account. They bought the stained glass and we budgeted 33,000 and it was only $5,000. So kudos to Nancy Stevens and Sharon Ziegler. Rex brought up at the last meeting to make surgery suites the fundraising focus, and so the board agreed. We didn't have an official vote or anything, but we just kind of started moving in that direction. And he suggested moving it into two pieces where we focus on scopes first. So that would be maybe building on the first part of the surgery section where we could just do scopes. And then, going forward, looking at the surgery suite. He's working with Vizient maybe to get a quote and see what that would look like. The foundation board was still interested in knowing the assisted living numbers, like what the 30,000-foot view would be, like how many rooms would it take? Knowing that we have 700,000 in the bank that is just sitting there for that purpose. So, you know, and if it comes out at 2 million, it would be hard to raise the rest. And so, they were still interested in that, but they agreed to focus on surgery. So we will do all. There's some hesitancy about a path to 12 million to build the surgery suites, but if we bite it off in smaller chunks, where we just focus on scopes, or we just do this, or we get more accurate numbers, or things that could be a lot cheaper, we can start to do that. So that was kind of the gist of the conversation. We're waiting to get the microbiology equipment, but beyond that, so then our projects are complete. So BioGives is July 15th. Encouraging everyone to give. We get the match from the Hughes Charitable Trust, so the money's doubled. Boots and scrubs we're going to cancel and just not do for now because we don't. It's hard to fundraise for the surgery suite until we have a little more information, right? Like a drawing or a price or any sort of things. We need some details about that. So we agreed to cancel it for now and then maybe see if we can do something later. And Foundation 23 is September 19th. So that's it. It's all good. Do you guys have any questions for the foundation?
Thank you, Carrie. Appreciate the update. And next on the agenda is Finance Committee. So I'll turn the time over to Kenda, Rex, and Jeff. Whoever's presenting this evening.
We have the budget later on, right?
Yeah.
Okay. So we did have finance committee meeting on the June the 17th. So anything you want us to share in particular? You guys have it in your packet, but for the people in the audience, we can kind of briefly go through it and we can kind of land on our financials that we covered. And I think the finance committee, they were comfortable with bringing this information forward to the entire board. So you can see inpatient data has been pretty much all over the place. The patient days, you have, such small volumes inpatient wise, so you're going to have major fluctuations. Outpatient visits were down. That was, obviously we'd like to see that go up, and we're going to talk in the budget, fiscal year 27 budget, some things that I think will address our outpatient visits, or at least our outpatient revenue. EMS numbers were down, urgent care numbers are downward. I know we had a med exec meeting yesterday, and we're really going to start looking at the urgent care numbers and try to see where we can. Where do we need to be as far as hours of staffing levels, and kind of the sweet spot. So, and that was driven by our providers. Imaging numbers again. I think we had hoped to see a little more activity in May, but hopefully in June and July, what I understand are the busy seasons. And it appears, I've been up at the hospital quite a bit over the last 2 or 3 days, and there seems to be quite a bit of activity out there, especially in the imaging area. So you see these numbers, and you guys have them in your packet. Lab test, it's invariable. I guess after doing this for quite a few years, lab had a really big month the month before, and I could have about predicted they were going to be down the next month. So numbers were down in lab. Clinic volume, again, we have we'll talk about in the budget things to address some of the revenue related issues by going with the rural health clinic model. But we obviously would like to see increases in patient volume, so we'll be digging into a little deeper that. I know that's on Jeff's radar to look into a little bit more, and I've had conversations with providers, and certainly they want to talk about some efficiency. Dr. Burnett's been really involved in it as well, just making sure the throughput's there and that we're kind of running things so that we become a place where patients want to come and try to have those numbers go up. So Long-term care days, I do have in my CEO report. May, we got down to, I think, 37, 39 residents. We're back up to 47 now, so the numbers are up. Don wanted me to report on that. And, again, we'll be working on narrowing the gap on the revenue and the expenses and deductions going forward. And then, again, it's just so exciting to have Teresa here because our days in AR, the Ocean AR days are 160. Those need to be in the fairly quickly. We need to have those down into the, we need to get to 80 and then industry standards in the 40s. So we've got some really old stuff. We need to make sure that we're handling that appropriately for the cost report. And so we can at least get credit through the cost report. So, unfortunately, this number is really, really high, but I think we will. And then we need to make sure that we have a kind of a process and making sure we're handling bad debt and financial assistance. Making sure that program's functioning like it's supposed to. I think those are the stats. Do you have any questions, any of the stats? Hopefully we're going to see growth in the June financial report and July. And then again, we're working on some things, hopefully just with our staff. And we got an incredibly welcoming hospital when you walk in the door. So I think we'll get around, and we've got great equipment in the radiology department, great providers, clinical folks. We'll just work with Carrie to make sure we're promoting it and trying to add more services in the community. So these numbers will go up, I'm pretty sure. Anybody in the audience want to address anything?
Rex, one quick question, and this isn't finance based, but given the fact that June and July are typically pretty heavy activity months for us, with the transition to hospital, which we've not been through in June and July before, are we staffed and ready to handle the volumes that we could see?
We have our chief human resources officer down there's nodding his head. So I know he's been out and around, and I do obviously round a lot. Our challenge there is I think we've got the right amount of staffing. It's just, I tell the agency folks all the time how much we appreciate them being there, but the reality of the situation is we need our own people. And then, I think we have some nurses that have graduated that have joined us. We're reaching out to some nurses in the community we know that have went other places to encourage them to come back. And we'll be bringing a plan for you guys to consider next month, looking at what we paid on the agency nursing and trying to work out an arrangement financially that, hopefully gets us over the house would keep half, and then we would try to roll things into the salaries and try to make sure we're on the front end of the recruiting salary piece of the equation. So, but I think staffing wise, but we do a really good job of flexing staff when we don't have the volumes. And I've more so than probably any other place I've been, we seem like, our dietary housekeeping and some of those folks in those departments, they sort of are multi-skilled without being called multi-skilled, but help out in other areas when they need to. So you got a lot of teamwork in your hospital. I'm really, really impressed. So, but I think we're in pretty good shape. We just need to look less reliant on the contract services, nursing, nurse aides. And I think then obviously our bottom line gets better fairly quickly too. So anything you want to add? You probably have a better feel for it than I do.
I was just going to say, from the provider standpoint, we're in good position, and that's in part due to the flexibility and cooperation. Of course, the ED department can handle the volume, but with the ED urgent care teams working together, they're always quite willing in terms of taking on extra filling in. So if we were to have an unusual busy time, I don't think it would be any challenge to have somebody come add to the team to make up for those busier times. So I don't think that's going to impact us in any way.
Okay.
Do you have anything you want to add, Raymond?
I could real quick. As we're posting positions and we're just filling a few hit and misses, what I've seen in the last 3 months that I've seen is a volume of people wanting to come here. That is a positive that we're starting to see. We're starting to see a fluctuation of numbers. And in the past, what I understood there wasn't a whole lot of numbers, but whatever we're starting to move, we're starting to get some momentum. That's a good thing. So it's coming.
Fantastic. Thanks for that. I ask only because I know it's been kind of a learning experience for us to juggle, volumes, but expectations from open to now, and it's been kind of a
We'll have some,
back and
we'll have
forth.
some benchmarking information. I know he's working on that too, so we can compare ourselves, but every small rural hospital is different. And so we'll just need to make sure that, we're kind of where we need to be. I think we have, what are we at, about 190 FTEs? Is that about right? So that's not too far off, but we just need to make sure the FTEs are in the right place. And I've loved the other places I've been, but I don't think I've ever been in a place where I feel as confident in recruiting people as I do here. And we had a physician come through, actually he's in a residency program in Idaho, and he came through, and this is where he wants to come. His family came, I gave him a second tour, the family loves it, schools, so, I mean, for the right person, this is the right, you can't beat this, so I'm anxious to, work with Raymond and Carrie and, just promote what we have here, so I think from the recruiting standpoint, I think we're gonna be in pretty good shape there too.
Thank you.
And this place, the other thing too, this place sells itself so well when you go around and I give tours and, it's probably the most enjoyable thing I do on a weekly basis is give tours. Our staff couldn't be any more welcoming, more friendly, more nice, more engaging. I know the physician that I showed around Friday, he emailed me back and he was talking about one of our employees talking about, hikes and climbing mountains, and was there, gave him a cell number so he could call. And it's just refreshing to take people around, and the people, when they leave, they go, are they really that nice? And I go, yeah, I didn't think so either, but they really are that nice. So anyway, but we'll monitor the HR or the staffing side of things pretty closely.
Sure.
You want to talk about the financials, Jeff, or?
I'm happy to entertain any questions.
Okay, so we're gonna talk about budget separately, right?
Budget, yeah, we'll do that separately.
I did just have one question on the finance packet that we get. So we used to, at some point, and I think it's honestly been some time, but we used to get a balance sheet as well. And we don't get that in our packet anymore. I was wondering if
That's fixable.
if we could see that too, or do you get it?
No, you guys need the balance sheet. Yeah, you do.
Okay, I
So,
think that would be,
I worked with some boards that prefer not to see that. I've always kind of drawn back a little bit from that. I welcome the question because it's
Okay.
certainly something I think you should see.
I can run through some of the financials if you want tonight, if you do have questions. On the revenues, and it was, it was not a great month, but it wasn't an extraordinary month either direction. Did you have the sheet of paper?
Yeah, I can.
You might just speak to it a little bit so they have a better understanding going into the budget.
The revenues,
Jeff, can I have you stand at the mic, please? Thank you.
sorry about that.
That's okay.
You're fine.
My first. Yeah, revenues were up a good bit, which is the good news. We've seen some of the operating statistics that Rex has already prepared for you. That's a good start. But as we're going forward, noting some of the things that were already talked about, like the days in accounts receivable being at 160 days, which is, our target's got to be in the high 40s fairly soon. One of the things that comes along with that is we did have to make some adjustments in our reserve for contractual adjustments, the difference between the bill that we send out and what we expect to get paid. And so if you look at the comparison on this sheet there, you'll see it's a little bit bigger this month because we had to make some adjustments to catch that up, to make sure that we're not expecting money that's not going to come, whether it's through the denied claims we've already talked about. That's really the biggest thing. Or if we haven't taken proper account for the fact that, and I'm just going to pick one out of the air, that Blue Cross, we sent $1,000 bill to Blue Cross. We expect them to pay $500 when in fact they only pay us $200. So we've had to kind of catch that up. And so you'll see a little bit of that in the net revenue number for this.
Well, you did it for aging too, right?
Yes.
We were under reserve probably on the.
And that's where that is coming from. It's just that reserve adjustment. Operating expenses, obviously over budget a little bit, some of the professional fees as we've had to transition from having, local team here. But certainly a little bit more expense than budgeted with the health tech team coming in, supplies being over budget. A variety of reasons why that is happening. Purchase services, $68,000 over budget, primarily reference lab usage, some lab tests being sent out. Arrival of some of the equipment, Madam Chair, you talked about, is going to help address some of that very quickly. So overall, yes, we had a tough month relative to budget, but we do see good things coming on the horizon when we talk about budget. I think you're going to see some welcome news there.
Well, it'll be helpful to have a year to compare to. I mean, we're just comparing to a budget, and I know with dietary, we definitely were off on our our budget expenses for dietary quite a bit. So I mean, some of the stuff, it's budget related too, but the bottom line loss is what it is. So.
Yeah, you have to have a little bit of a history really to kind of get that budget right. I think there's, the best effort was made to get there. And there's some lessons learned that, again, we'll share with you as we talk about the budget going forward.
And we will send you guys a balance sheet out, so you'll have one of those. So you can, yeah.
Thank you, Jeff.
Okay.
Okay, any other questions for finance? We will move on to leadership reports then. And I skipped CFO introduction. Do you want to make a formal introduction of Jeff? Sorry.
Yeah, let me go back, because he's got a lot of credentials behind his
Yes.
name. Too.
Sorry
felt
about that.
kind of intimidated coming
Just
into
over
work
that.
every day. See, where you at? There you are. So we have two guests here. So we have Kirby Johnson, who's with Senior Life Solutions, and you can see Kirby there. And then Jeff, actually I met Jeff at the Wyoming Hospital Association meeting 2 or 3 years ago, and he was the acting interim dean for the Masters in Healthcare Administration program at the University of Colorado in Denver. And so we were talking about some opportunities at Rollins, or maybe we could collaborate and his students could do some work for us and get a grade, and we wouldn't have to pay him. And I think we put some money into an account for travel or something, but they did several projects for us. And so he's, through the years, the last 2 places, he's definitely done some things, because he's just really good and knows his stuff and he can access information. So done a lot of, he's helped me a lot. He was available this summer, obviously, between semesters, and he was willing to come. His passion is rural hospitals. He was a rural hospital CFO in West Virginia and in Texas before he went into the higher academia ivory tower. And but he, we talked quite a bit, and this is a passion for him, just like it is Kirby. And we're just excited to have him here and to work with our team and get some things established, work with Michelle, our controller. And certainly, I didn't realize this until 20 minutes before board meeting, but Teresa and Jeff actually worked together at another hospital back before in the late 90s. So they have a lot in common. And I think they're really, I hate to use the word synergy, but I think there's a lot of synergy about what these two bring to the equation and how we'll all benefit from that. So anyhow, welcome. Glad Kirby's here too. So
Yeah, thanks. Thank you very much. Happy you're here, both of you. Okay, now we can move on to leadership reports. And first up is health tech update. And I believe that Dom is with us this evening, not Mark. Mark will be our new lead. But I believe this is Dom's last report with us tonight.
we'll have a cookie for you, Dom.
Okay, have a cookie for me. Yeah, thank you very much, Tanya. Mark will be with you starting next month in next month's board meetings. We're just finishing a few other rotations, so I had to take on his responsibility today. Thank you very much, and good evening, good afternoon, everybody. I have a few things to update everybody on. Rex, if there's anything that I do say which is incorrect or something that might have transpired more recently, please do jump in and just correct me if that's the case.
I think you'll be spot on, but we'll do that for sure.
The first thing I wanted to mention was the Rural Transformation Fund. For those of you who may or may not be aware, there was a meeting on the 16th of June with the Wyoming Department of Health. And the reason why I wanted to just discuss this briefly is because I know that Rex is setting up a meeting next week. I might possibly be involved in that because I'm working with a number of our hospitals on the Rural Transformation Fund, and then one in particular close to you guys, which is Hot Springs. And from what I've seen the categories for Wyoming, and I believe that there are a few opportunities, either 2 to 3 or possibly even 3 to 4 potential areas where Sublette could get some money. I've been told by my counterpart at Billings, who's the Chief Regional Network Officer, that the application is probably going to be relatively simple and shouldn't be too cumbersome. And I'm looking forward to seeing that application, which they're expecting to arrive next week. But I do see a few different categories that I think that we could take advantage of. Two of them, or one of them in particular, is $350K for a Center of Excellence data submission. This should be relatively simple. So we don't know yet what the data is going to be requested for, but I think that in terms of a Center of Excellence data and analytics section of that, I think that we can definitely get money there. I also think that because we have EMS, I think that there's an opportunity for us to get money there as well. So I don't want to come up with a sort of global figure, and I know that Rex has Rex's full attention, but I really do believe that there is an opportunity to get money for our hospital as well. I know that the deadline is the 31st of next month, so as soon as we do get these applications, obviously everybody's going to have to move very, very quickly to get this done. I just wanted to touch on very quickly on just highlighting a few things from Teresa's presentation for the board, and hopefully this will help you. I can't stress enough the importance of a few different areas with regards to revenue cycle. And they're just a few really, because it's how the whole process starts. If it doesn't start well, it doesn't end well. So the importance of accurate patient registration is number one. The second one is the accuracy and the cleanliness of your clean claim rate is number two. If you get the billing out the door and the claims are clean, you get paid. And it's really just as simple as that. So those two issues are the most important things right out of the gate. And then Teresa and Rex were referring to DNFB. It's really, really important that, and I'm sure Jeff will address this, that the hospital arrives at some sort of point of where what they feel is a fair and realistic number of days for lagging for DNFB, whether it's 10 days, 7 days, or whatever it might be. We try and push most of our hospitals to work on the basis of 5 days on DNFB. So if you get everything out of the door clean, you have clean registrations, and you're watching, I've had many conversations with Margaret over the last few weeks. DNFB needs to be watched and worked on every single day. And you know, if the industry benchmark rate is somewhere around 75%, we have our average in our hospitals running at 88% on a clean claim rate, and that's across all our hospitals. So we can definitely get it to where it needs to be. It's obviously just a case of time and attention to detail. So I wanted to make that point. The other thing that I wanted to talk about briefly was, I'm sure you're all aware of the property tax cut made in Wyoming. I understand that the first tax cut was 25%. Obviously, this is a great thing and a good thing for people individually. But as you know, it's going to have a very, very negative effect on many, many initiatives within the community across many different areas. What I have heard, and maybe you know more than I do, is that they're talking about that being increased to at least 50% on the ballot in November. So I think that that's something that, you know, one should definitely look at very carefully and do whatever you can to for the community to make sure that certain areas within the community services are not being lost. At the end of the day, in my opinion, and I know that this is going to happen, if they cut the property taxes, they're going to catch the money somewhere else, and it's more than likely going to come from sales tax, an increase in the sales tax rate. My third topic for today is compliance. Cherie has been working closely with Lena, and without getting into too much details, it looks like that we are just looking at a process deficiency that requires corrective action on a compliance, still on compliance. Sorry. Did somebody want to say something? No.
Nothing on our end, though.
Sorry, Tanya?
Just said nothing on our end. We're just
Okay.
listening.
Thank you. Cherie is also continuing to provide compliance officer orientation to Christy. She's completed 5 sessions and she still has 5 more to go. There's been a lot going on. My 4th item is GPO and supply chain. I know that Rex and our Jeff have been talking almost every single day. There's a lot going on in GPO. And I thought I'd just touch on a few of those things very quickly. We've been having this issue with Henry Shine, and after 6 months with no progress on vendor confirmations and contract loads, we are now looking at and this is in terms of acute care contracts. We're now going to be making a change. Jeff is following up on a large number of credits and rebills for Sublette. And we've asked them that they pay us back for the overcharges resulting from improper contract loads for the period of 3/2 to 6/12. We're hoping to have this done by the 31st of this month. Medline, we'll be moving to Medline as the primary med-surg distributor effective 17th of August. And we'll most certainly see additional savings over Shine with the Health Tech corporate Medline contract. All signs so far are pointing to a smooth transition in that regard. With regards to potential future OR build, I know that Vizient and Jeff has connected Vizient with Rex. Obviously, Rex knows a number of people at Vizient, but we're going to see what we can get out of them in terms of basic OR bill costs, and to make sure that we get as much directional data from them for no charge as we can. I know that Rex has signed the Braun document for better pricing on IV solutions. Sublette has been moved from access level to tier 3 in the pricing structure. Then briefly discussed master item file cleansing. Minimum charge there is $24,000, but we're going to get that down hopefully to $10,000 because of the car status. So more to come on that. Jeff has also been providing ECR training for Mike Straw. Health Tech sponsors Sublette membership in the ECR capital equipment quote review. So that's what I have on GPO. And then let me just find my next item. I know that you have on the agenda, my next item is CHNA and strategic planning. We touched on it in the last board meeting. And I have some documents that I can forward through to Rex. I have those in my hands as of today. And Rex, I'm not sure if you've connected with Julie, but I know that you are aiming and hoping to get the CHNA done in September month, if that's correct.
I think so. And I think Judy and I are supposed to talk on Friday, I believe.
Okay, excellent. So we know the importance of that. And as I said, we're going to bring up the timeline. And I'm sure once Rex and Julie have had a meeting, we'll know where we're going in that regard. My 6th item is finance. And I did have a catch up very briefly with John Freeman. And I know that John has met with Jeff and Michelle. And Jeff and Michelle were working on improving the process for calculating required AR reserves for the May financial statements. And I know that Jeff and Michelle are starting to use our new CEO dashboard reports and the reports from Ocean to calculate expected payments and required reserves by major payer. So this is still obviously not perfect and far from it, but I think we are moving very, very quickly in the right direction. And I most certainly was very, very happy to see Jeff on board and taking some pressure off Michelle, giving her mentorship and direction. And I'm very excited that we're going to be able to start getting some really, really good traction. I recently helped out Kayla. When I was last there, Rex, I had a meeting with you and Kayla with regards to radiology. As you know, I gave Kayla my point of view on the radiology costs, which she seems to have been very happy with. So hopefully that is moving in the right direction now. If she needs any more help from me, please just let me know, and that will not be a problem at all. Yeah, and then just my last item is that Mark will be visiting the hospital week commencing the 6th of July. I know that he's planning on having a get-together with Tanya. Obviously, he'll be having many meetings with different people within the hospital, obviously spending a lot of time with Rex, but I'm very happy that that's going to happen. And that's all I have for tonight.
Well done, and next time I'll slide you after me in the agenda so I don't have to follow you, so. I need great content, but the accent, I mean, it makes it really.
Thank you.
Dom.
Well, and Mark will get to go to a county commissioner meeting with me too, so that is priceless as well.
There we go, nice.
Hey, good job, thanks.
Does anyone have questions? Thank you, Dom. Thank you.
My pleasure.
Okay. Rex, you're up with your CEO update now.
Not only is it the friendliest hospital, it's almost the most I think it is the most photogenic hospital. These people take great pictures. So anyhow, so we wanted to add them to the PowerPoint. We have all staff meetings coming up later this week and next week, and it seems to keep people more engaged if their pictures of their friends and their pictures are in the PowerPoint. So, and I got permission. I didn't take any pictures of people that didn't want pictures taken. So this is my report out items, I guess. So we know Ocean is our EMR. It's an Epic platform. It was becoming pretty apparent that we were not getting the most experienced people on our team supporting us. And so, and we did have a significant amount of a bill to them that was hanging out for travel and lodging during the implementation. And we had probably one of the most productive hour-long phone calls I've had with the VP for Ocean. He's got a great professional track record. If you look him up on LinkedIn, and he is joining the organization and to support the CEO, but they ended up splitting the difference with us on the funds that we owed them. And then we're going to be stretching out our payments to them over a year. So that's nice. And they've also made some changes on the team that's been supporting us, I understand. And I think we've got a lot more experienced people on the team, and he even volunteered to mentor Michelle and our team. And, again, we'll see how this plays out, but he said Ocean would like to make Sublette County Hospital their beacon hospital, but a hospital could achieve with Ocean as their partner. So we shall see. We trust and verify, but at least all the things were said. And certainly early on, we're seeing, I think, some examples of a commitment. So we'll keep you posted, but I think the first meeting went really, really well. I did go to the State Land and Investment Board SLIB meeting, which I have a great story from Rollins about how that all works out, but the Mineral Resources Grant. So I made it there. It was left on Wednesday. The meeting was on Thursday. I found out a couple things. One is that they love Carrie. So I bet I had 10 or 15 people come up and ask me why I was there and not her. And so, you know, we went 3 deep in the bullpen, but I'm here and I've got a job to do. And the other thing I really appreciated, Carrie, she told me about a secret door that I could get in that, I mean, made me look like a leader among people. I went in and some people stood there like, does this guy know what he's doing? And they followed me in. But if not, I would have never found it and I would have been late and we probably wouldn't have got the grant. So anyhow, thanks for all you did. So, but they did right before the meeting, I think we asked for 170,000 and they approved us of 130. So it's 50% of the total project to get the ambulance box remounted and then a chassis underneath it. So the hospital, you know, will be, I think 17% of the total the hospital will need to find funds for. The foundation put in 90,000. I think the total project was 270. But we were funded for our portion of it. I know it was interesting to sit in the meeting because there's through the auditor at the state level, they had found some other money and some of the people I think marbled and they have a special meeting on first part of July, where they're going to see if they can help fund some of the ones that were not funded initially. So I really appreciated going, but I know from my time there, they prefer Carrie to go. So and if you want to schedule vacation next year at the same time, program updates, rural health clinic. We're having weekly meetings on the rural health clinic status. Bailey, previously an agreement had been signed for that, and they are doing a pretty good job of leading us through that, I think. We do have to decide for a period of time, we have to have a credentialing organization, joint commission, or there's 2 other groups. We will probably not go with joint commission, but we're working through kind of the down select there. But Christy and Vicky are doing an incredibly good job on that. And we will keep you posted. I would assume we're probably 90 days out, maybe longer, but that will be up and running. And you'll see on the budget how that impacts our numbers without any increase in volumes. Swing bed. We had obviously gotten the agreement done with Proactive for a year. We'll RFP it in at the end of the year. They've been a great partner so far. We need to get some patients in. They're going some training now to on our system. And I think we're working on a separate medical staff credential, or not credentialing, but a status for them. But we just need to get a couple patients in, get the state out, certify us, and you'll see that impact on our budget of fiscal year 27 as well. It's probably the most significant budget item that we have. So as far as revenue is concerned, 340B, I had really hoped we would have that up and running by the end of the year. I think the earliest it will be possible is towards the end of 3rd quarter. We have to submit our critical access hospital cost report, which is due in November, and then we can apply the first month after it's submitted. But my understanding, can't just be submitted. They have to acknowledge it and had done a kind of a trial look at it. So we will get after that as soon as we can, because that certainly has some very big positive repercussions for our budget in fiscal year 27 as well. We backed all of our numbers back. You'll see when we go through through the budget, we've moved everything back where it needed to be. So there's no overstating, or, I mean, you can see kind of where it is, because when we get to the budget, we've been incredibly conservative on everything. And when Jeff goes through it, I think he can just point how conservative we've been. Operating scope room plan development. We'll talk more about that going forward. Vizient certainly has the ability to go in and get a group purchasing organization pricing on equipment. They're really innovative when it comes to phasing things in. Carrie gave me some drawings. I think we're going to get some drawings, and that I think not only will help the project, but it'll probably even reduce costs. The $12 million number, at least preliminarily, is significantly high. Hopefully we'll be in the neighborhood of 2 million or less. So we'll see how that all plays out. It's just amazing when you use group purchasing organization pricing and you can phase it in with big national group buys, you can really drive prices down. So we'll keep you posted on that. Dominic did a great job on the rural health transformation funds. I think, Gary, I don't know if you want to speak to it, but we do have plans internally of what we will do to handle it. And quite frankly, I missed the last meeting and was not totally present the last one, but Dawn and I mean, you guys have been involved in it, so do you want to speak to it at all? I mean, Dominic's spot on with the categories and things. Carrie, do you want to speak to kind of what our plans are going forward?
Basically, it's categories of funding like Don spoke to. There's one for rapid imaging for strokes and traumas, which we do offer. Basically, the system is if you offer the service, there's a fee associated. So rapid imaging, strokes and trauma, you get, to 150,000 or 500,000. If you offer OB, you get 3 million, but we don't offer OB. So it's just a system that 24/7 ER is on the list. The imaging's on the list. EMS is, I think 750,000, 350,000 Center of Excellence. So it starts to add up pretty quickly. And then there's two categories, the making Wyoming healthy again. Rather than trying to cram that in because it is such a 1 month timeline, they're gonna have a third party sort of roll out a year-long program. So they have to commit all the funds by October. So it's gonna happen really fast. But they're gonna commit to a third party to help make Wyoming healthy again, and then that party will roll out grant opportunities for programs. The same with the workforce training. You're not gonna make someone decide between July 1 and July 31st if you want to be a nurse or not. They're gonna give those funds and obligate them to a third party that'll roll out a workforce healthcare training program. So those are both in the works, but Dom's right, the grants released July 1 and it's a really fast turnaround, so we'll jump right on it.
Yeah, real quick. So on the piece for making Wyoming healthy again, you said that the state is getting a third party.
Yeah, the state chooses the third party.
Okay, and what's the timeline look like for that?
It's between July 1 and July 31st.
Okay, but I mean, like after that's implemented, say for like
Then,
our organization.
This 205 million is for the first year, and each year you get sort of you get a penalty basically if you don't spend it all. So they want to be sure and go to the 205 limit. And so that will be a 1-year program. So whoever, Align is a grant company out of Cheyenne. I don't know who they'll choose to be the third party, but whatever they choose, they'll roll out what make Wyoming healthy grants, and then we can apply for those within the next 12 months.
Okay.
Does that make sense? Same with the workforce. And I don't know if they're using their own Department of Workforce Training grants to do programs, but the other categories are pretty clear cut. Either you offer it or you don't. There is one on infusions or dialysis or something.
Dialysis, yeah.
Dialysis if you start it up. So we might have a decision to make in July.
There's been a lot of technology advances in that space too. So I do think it's something we probably need to look at. And I don't know, Raymond, did you have anything you wanted to add? Very good job.
Yeah. So any startup questions we'll bring to the phone.
We did have some backup plans because it was pretty vague and there was a lot of uncertainty. But I think over the last couple of meetings, there's a lot more certainty, and certainly Carrie and Don have really good feel for where we need to go. So if we need to get help, fine. As you can imagine, there's a lot of companies out there wanting to make money off of this program. But I mean, I think we're in good shape here. We can handle meetings. We'll try to make sure we're there's no money left on the table.
For sure. It'll be a great.
It will be so, and we're fortunate to have your expertise here to write the grant, so. We are doing employee survey, so that's a bit scary for the new guy starting, but we will see how that plays out. So it's supposed to be turned in when?
July 1st.
July 1st, so we'll give you that report. We'll at least know what to work on and have a baseline, and then HR will probably get involved, right, and put some plans together. Yeah. We do, and this was actually came from Health Tech, but I was aware of it too. Vizient's our group purchasing organization, obviously. Well, when I worked there, they had an employee discount program. And so they extended that to their member organizations. And so our employees now can access the Vizient program. And it's not nearly as robust as it used to be, but it really does help on travel, cell phone usage, computers, those kind of things. And I did ask Lena if you guys could be involved in it. She said no. So I asked. I was looking out for you. But the employees all they have to do is sign up and they're going to go. So I mean, it's a nice opportunity, I think, maybe to save money if they would like to do that. So and we'll talk about it in all the staff meetings if somebody needs help signing up. So next slide. I just am really focused, I think, or one of my focus areas has been vendor relationships. I mean, we want people to be loyal as vendors. We want them to do what they said they were going to do when we mostly pay them. And so we're really working on that and trying to make sure, that we're, holding people accountable, that we know what we're getting with the vendor relationships, what we're paying for. So we're not quite there yet. Michelle's been a big help on it as well, and I know Jeff will be, but it's just the last couple of places I've been. It just seems like you sign agreements and then the checks start, and we want to make sure if you sign an agreement with us, we're going to be a great partner, but we're also going to expect you to do what you said you were going to do the way we expect it to be done. Medical chief of staff, any questions on that? It's just, I don't know, it's a passion of mine just over the last couple of places because I've seen the abuses and how organizations get taken advantage of. So medical chief of staff results. This doesn't happen much in our country now, but Dr. Hasty was unanimously reelected for his position as medical chief of staff. So I didn't get invited to the victory party. I was a bit disappointed by that, but maybe as I'm here longer, the trust develops, providers will invite me. But anyhow, so he's up for another year, and obviously people are excited because it was unanimous. We do have, if you
think it's 3 years.
2 years, okay. Well, good. So he's not having to run every year for it.
Right.
I mean, I know take away from his job of seeing patients, so yes. If you guys are bored Friday, we'll have the regional CEO meeting in our facility. So the hospital association will be here and we will be having them. I think they get here right after lunch and we'll be here till 3. So anyway. Human resources, I asked the people that directly report to me on the senior leadership team to put in some, let me know what I needed to let the board know about. So, I mean, really the HRS, Human Resource Information System, is a big priority. And I think once we get that up and running, that will fix some of the other issues we have going on. So we do have a compliance and ethics hotline that's, I think, up and running now, right?
July 1st.
July 1st. And then just working on how we recruit, but focusing on retaining people too. And we'll have a new employee orientation starting. We haven't had one for a while, but making sure we do that right. And then we check in with people every 30, 60, 90 days, see how they're doing. So, I mean, retentions is as important as the recruiting piece, especially right now. And then looking at just pay and compensation, getting some salary grades put together. So needless to say, Raymond has hit the ground running and he has a lot going on. So, but he's got a good team. Teresa's back there. So I think they'll get everything done and we'll be in good shape. Nursing, Vicky's actually gone, but she just wanted me to let you know that they hired a new full-time hospital RN that had graduated. And then she has some numbers there and I can send this PowerPoint out to you if some of the stuff you can't read, but just kind of giving you an idea of the volumes we're seeing in the various clinics. Heritage Home, we talked about, census is up, and Don said no staffing concerns at this time because we have enough people. We just obviously would like to have more of our own. So, this definitely, I was supposed to print this out before I came, so I know you can't read it, but this is the project list that we've kind of handed out. It's starting to turn green. It was pretty cool because our printer and it made it kind of blue green, so it made it look like it was more high tech probably than it was, but until we fixed the toner cartridge. But we are making progress on things, and we'll send this out. Make sure we email that tomorrow out, and you guys can look it over. I am sending a weekly report out. I think until we all get used to each other, it's nice for people to monitor what the CEO is doing and making sure that I'm doing what I'm supposed to do, and for no other reason than that. But anyhow, hopefully, I mean, it has been a pretty busy couple months, but that's what we need and that's what I like. So Carrie every Monday sends out a Monday morning report. I have been sending the walk talk out, but I'm going to go back to monthly, I think. So it's sending out. But anyhow, just kind of from the perspective of kind of what's been going on. So we'll see that. And then I really would like to connect kind of what's going on the medical side of things, our providers. And so we do have medical exec committees as needed. I think no less than once a month. Is that correct?
Hopefully. We've been doing a little more, but we'll get back to once again.
And then we have our provider meeting, and I'm proud to say I think every provider was at our provider meeting last was it a week or two?
Yeah, we had 14.
It helped that their incentives are kind of incentivized by attending and they just got some information. But I either thought they were as a coup d'etat and they were out to get me, or they were starting to buy in, but I don't know. We'll see if it continued. But it was a really good conversation. We had everybody there and participating. So I thought it was a really good sign. So, but yeah, we'll keep you posted on some of this and make sure that the information is going back and forth between the board, medical staff, foundation board going forward. All staff meetings start tomorrow, I believe, right? And Monday. So we try to make them fun, trivia, drawings, sharing information, not only what happens tonight, but, other things that other people in the, the things they need to know about if they're going to work at the hospital. So we want them to hear about it first and us and not at the grocery store. So hopefully we'll have a good turnout. And then you guys are starting the new employee orientation. So, just aspirationally, we want to be a place where patients want to come, people want to work, and providers want to practice. So that's kind of, I think, what's driving the senior leadership team anyhow, and our directors. This may be dry and boring, but we've really spent a lot of time, and this has been Kaylin and Danny have been working on most of these charts, but like, how do we credential our providers, making sure it's as efficient as it possibly can be? Because if we don't get people credentialed, they're either delayed getting on our medical staff, or we're slowing up the process over there. So this is a really good workflow. And we went from 60 days credentialing a provider down to 17, I believe. And I was told, don't count on that every time. But that's what, when you start boxing things and moving things around, you can improve processes. So the other one, we had some things get out of line with provider recruiting. So this workflow keeps us all accountable and make sure that the providers are involved in it before we get a contract or a letter, an agreement in principle. And we have everything happening so that we get buy-in, so we don't run in and get to the end of the process and find out maybe it's no go from a credentialing standpoint. So anything you want to add? You were instrumental in driving both of these processes.
Well, I'm just saying, we're learning from the process.
They call them, you guys call them workflows here. I'm used to calling them, project management or something, but we call them workflows here. But we're going to be putting anything that we feel like is not efficient, we're at least going to draw it up on the board and see if we can move things around and make it more efficient. Plus make sure we all know how it's supposed to work. So this is just the real transformation program stuff. We can send it out if you guys want to kind of review the buckets that Carrie talked about and Dominic. And I know this was covered last time, but I wasn't sure before we started. And then I was reminded, but Ashley Merriam was our Daisy Award winner. And I had Dr. Hasty in there unanimously re-elected. So both got them both in the same picture. So old business, I guess. That's my report. Do you have anything you want to ask? I'm going first, Dominic, next time.
I won't be, that'll be Mark's problem, so that's okay.
No, you'll close it and it'll end better. So do you guys, any questions on anything?
If you wouldn't mind sending out the rural health transformation.
Sure.
Again, we have it,
And I got permission to, I know Health Tech has it, probably Terry has it too. This actually came from one of the vendors that wanted to help us, but I got permission that I could share it before I did, because I didn't obviously want any other issues, but we'll send it out so you guys can follow, because it's big. I just hope, this is an editorial. I hope it doesn't, COVID, there was all this money going back and forth. I just hope that we've learned from that experience, not our organization, but other organizations, that it becomes funny money and then people start doing things and then you've got to pay the piper. And we just need to make sure, and I know we will here, but just make sure that we handle the money properly.
Absolutely. Thanks for being cognizant of that.
Yes, sure.
I think it's important, especially as quickly as they're trying to turn everything around.
It really is, to make sure we get double checks. And we have the expertise here to make sure. I just know in Kansas, we handled everything with dual approvals. I didn't do anything because I didn't want to have to explain it later, but a lot of people lost their jobs in 2022 because of the COVID funds they got. So anyhow, well, thanks. Appreciate it.
Thank you for the comprehensive report. It's a lot of information. Thanks for all the good work you're doing.
I appreciate you guys.
Questions from board?
Thanks, Rex.
Thanks, Dominic.
Okay, thank you, Rex. Next on the agenda is old business. We have just a couple of items there. The first being approval of payroll and bills. Up for the board to take action on the May 2026 payroll and bills.
Madam Chair, I move to approve payroll and bills for the month of May 2026 in the amount of $3,124,097.79.
Thank you. Kathy. We have a motion.
Madam Chair, I'll second.
And a second. You, are there any questions on any of the information provided there? In. Okay. On the motion to approve payroll and bills in the amount suggested, all those in favor, please say aye.
Aye.
Aye. There are no nays, I'm assuming, since it's just the three of us, and the motion carries. That puts us at strategic planning discussion. This is something we delved into a little bit last month.
Yeah, and I can
so-
start it. I think Dominique will want to share some information as well, but I think it had come up at the last meeting about the need for a community needs assessment, and there's definitely a requirement to do that. The health tech will be able to do that, but I think, I mean, our plan would be to do it in September when hopefully vacations are over and snow starts coming. And let's do that, and then the medical community definitely wants to do a medical staffing strategic plan. So we can kind of plan ahead, because obviously we have, a young doctor that wants to join us, and do we have the numbers to support it, and kind of looking at, career positions with certain providers are, what they're doing, and we could possibly doing. So that, I think we could start that at the same time and then roll that all into a strategic plan. So, and we'll talk in new business over USDA. I guess they wrote it into our contract about having a financial strategic plan assistance. I mean, we should have a really, really good strategic plan at the end of this. So one that's directional and one that's, we feel like is, helps us, not only anticipate issues, but also plan for them and be well prepared for the future. So I know, Dominique, you want to speak to the community needs assessment and the strategic planning?
Yeah, there's actually just so much involved in each of those items. With regards to CHNA, there's, you start off with, scope of services, then you look at methodology, deliverables, you have to appoint project leaders, you've got round tables, you've got interviews. I think that if it's okay with you, I would just like to email out a strategic planning template and a CHNA template to the board as well as to yourself, Rex, if that's okay with you and Tanya.
Yeah, I would love that.
Okay, you'll see that there is and as I think I mentioned in the last board meeting, there is a ton of work involved. There's a lot of time involved, but at the end of the day, it gives you your North Star, and it really gives you an accurate assessment of the current situation, potentially where you want to go. And I think what's also incredibly useful, most importantly, very, very useful, is that you overlap that and tie that into your financial planning and budgeting, because now you've got some data or data points that are that have been carefully looked at and worked out, and you're not coming from a thumb suck point of view kind of attitude.
Sounds great. Thank you, Dom. I'm excited that we're having the conversation. I think it's time to move forward and do some of these things. And it's my understanding, you made the suggestion last month that we appoint a steering committee of board members to help with that work, but I'd like to wait to do that until we have some guidance from you with your plan, and until we've filled a vacancy on our board and have our full board here. So.
Yeah, absolutely. I do remember us talking about that, and I think that's where Julie will be able to really guide you in terms of how that committee should be set up, just based on her experience. And if you don't like what she says, then I would just give all of it to your new board member.
Sounds
Duly
like a
noted. Okay, thank you.
No
Dom.
problem, sir. I will make sure that these two templates are in your inbox this evening.
Thank you. I appreciate that.
Sure thing.
Tomorrow morning's fine too.
Okay.
It's up to you.
Hey, Dom, I have one question. Can you just speak a little bit to how the community needs assessment is sent out to the community? Like what that looks like?
Yes, just let me just try and give you some more accurate information here.
Snail mail to every resident of the county.
Okay, I kind of thought that was the case, and I was curious how well
It-
people respond to that, you know?
But they may
Yeah.
be some calls too.
Some hospitals are putting links on their website, but it's difficult because people from outside your county do it. So they shy away from that a bit.
It is kind of old school. So snail mail is definitely also use online software, third-party software like SurveyMonkey, and most certainly we are now, and we have been for quite some time, also using social media accounts, Facebook, Twitter, and then of course email as well. So. I think we cover it pretty well in terms of the different avenues for getting the data.
Okay, great. That makes sense because, in order to reach the whole community, you got to do it in different ways.
Yeah, I mean, I doubt very much that we'll have Snapchat, but I think you know what I mean.
Dom, one more quick question along those lines. Is it typical to enlist the help of some of our auxiliary partners to help get that information out and to gather that information? I only ask because I know that public health in the past has done something similar and played a role, and maybe some of the other auxiliaries that we currently utilize.
Yes, I
Is that
definitely
part of the
would
plan?
definitely would encourage that as well, because it also just helps. It also just helps, from a triple check and a double check, triple check, in terms of the data that we're getting. So it is helpful.
Okay. Thank you.
My pleasure.
Okay. Any other questions about the needs assessment? Okay, we will move on then. That is the end of our old business material. New business, we have a couple of action items right off the top. First is we need to remove our resigned board member from our being a signer on our bank and investment accounts. So there is a resolution in your materials that you need to take action on.
Madam Chair, I would make a motion to approve resolution number 8-2026.
Okay, thank you, Ashley. We have a motion, and a second. Any questions or concerns in this regard? For discussion? No. All right, on the motion to approve resolution number 8-2026, all those in favor, please signify by saying aye.
Aye.
Aye. Motion carries. Next item is the fiscal year 2026 budget amendment resolution. This is to amend our current budget. Would you like to speak to that, Jeff, or Rex? Anything?
You can.
You have slides on that?
Well, they can't read it, but that's.
We have the resolution,
Okay.
the numbers.
All right, well, that will go into some of the fine print behind the numbers that you see there, Madam Chair. I'm going to start with the revenues because that's really where a lot of big changes are expected. We've talked about some of those this evening, and I think there's some good news to be garnered there. The base sort of case for our business starts from the departments. The departments give us their projections on volumes, and we've built that into the budget. So we kind of have that same store comparison, and we're really staying at a fairly static state. We're going to change some ways in which the revenues are gonna come in. But the operation in which we're budgeting around starts from our managers. All right, the big thing that is happening obviously is the swing bed conversion, and that's a big revenue opportunity. We expect to have about 1.5 patients a day in the swing
This is
beds.
Hey, Jeff,
amendment,
this is the amendment piece.
2026 amendment.
Yeah, not.
And I can speak to some of that. So yeah, don't leave there. Go stay up there.
I'm sorry, my glasses aren't taking, I can't reach them.
Yeah.
That's okay. That's okay.
So I think it's a Wyoming statute that you have, this is unusual, or this is different than any place I've been. Usually you just closed out, last month of the fiscal year and you knew where you were off. So, but we have to file an amended budget here. So you can see salary and wages, the amended budget were less. Our professional services fee were less. You have that?
Yeah, I was looking at the wrong slide.
Yeah.
Well, again, you can't see it. So I mean, next time you make sure, but if you want to speak, that's.
The salaries decreased by about $2.6 million. The original budget assumed full year CEO, CNO salaries. Also, the adjustments to the budget of FTE positions. We're going to be also transitioning to a self-funded health plan, a great move on for the benefit of this community here. And it's keeping money within the hospital rather than giving it to basically the people that want to take money away from us, the insurers. Supplies are going to increase about $600,000. And really that's related to the food service operation. And we talked about that very briefly in the meeting already, as well as pharmaceuticals as we expand some of the volumes in the hospital, and also housekeeping supplies. So we're keeping the property looking as good as it does. Purchase services are going to increase slightly, about $278,000. Again, that goes back to the reference lab comments I talked about earlier. We expect to see some of that happening, even while we're bringing in the equipment that will cut down some of that reference lab use. There's going to be a runway for that we're going to have to go through to bring those items online. We're going to continue to spend on that space. Also, some additional expenses around the OGE. Legal and audit fees are coming in lower than budget, so you'll see a $300,000 improvement there. Repairs and maintenance, as we've gotten better understanding and better history of what's going on with the business, that's going to increase about $500,000 from the original proposal. And a lot of that has to go with the Sublette Center renovation. Also, there are some expenses for signing maintenance contracts that be reflected in the first proposal. Insurance is expected to go up about $375,000, primarily due to rate increases from our carriers for property casualty, and also our professional liability coverages. Other expenses, really, this is going to be a challenge that Teresa and I have to face, but one of the biggest things that we're building into the budget right now is an expense for credit card processing fees. Currently, we've been absorbing that, and we're just coming to the realization as we review these documents, we see the amendments that have to be made here. That's a lot of money. And it seems like it's a growing practice out there that businesses charge the commission going to the credit card processors. We need to do some more research before we come back to you with a proposal what we want to do with that. In the interim, we're going to take the more conservative approach, budget for the increase, and hopefully we can recap some of that or recoup some of that in the coming year. Revenues, the original budget assumed that the clinics would convert to RHC status earlier this year. That's obviously not going to be happening until later this year, and I can talk more about those assumptions later. Also, the reimbursement assumptions were based on uncertain estimates on the reimbursements. We are much more confident with those projections now.
Well, that's where it helps getting historical data so
Yeah.
we can build them. It's a brand new hospital. So I mean, a lot of this was just, shots in the dark.
Yeah.
So I mean, I'm really kind of amazed we were as close as we were. So it's a good job.
So the additional revenue coming through ARPA funding and also some money from the hospital foundation for the MRI. So those are the details behind the changes that you see there.
Thank you, Jeff. Thanks for going through that. Does anyone have any questions for Jeff regarding those assumptions and the need for the amendment? I'm Jarvin to approve the budget amendment resolution number 9-2026. Okay, thank you, Kendra. We have a motion.
Madam Chair, I'll second.
And a second. Any further questions or concerns? I'd just like to say I guess I kind of assumed we would be in this position with, we had to make a lot of assumptions without those historical data, so it's difficult. All right, let's take a vote. All those in favor of the motion to approve budget amendment resolution number 9-2026, please signify by saying aye. Okay. There are no oppositional votes, I'm assuming at this moment, so motion carries. We will move on to the 2027 final budget resolution.
This is what I was going to was already talking about before.
Sure.
Madam Chair, you and the board, my condolences. You're going to be like my students who get very tired of hearing. All right, so next slide, let's dive right into it. We're going to break it down into the key components of the financial statement, the operating revenues, the expenses, non-operating revenues, which I think you're going to find some good news there, and then just wrap it up. So let's take a look at the operating revenues. There we go. All right, so as I just mentioned, really starts with the departments. We are going to increase the swing bed revenues by about 1.5 days. Now, based on the comment, Madam Chair, you just made there, I wanted to try and kind of help advance the ball a little bit with my assumption with the swing bed revenues. We have a decent idea what it's going to be, but not really sure. One of the things I do as an academic is I have access to all of the cost reports around the country. So I went to the hospitals that have, rural hospitals here in the state that have swing beds, and we took the average payment from those hospitals. So we've got a pretty good idea. We know we're going to be close on that projection once we are able to actually get that into our cost report. So very confident that that number is going to be something we're not going to see big swings from. The new services, Senior Life Solutions and Wound Care, are built into the baseline assumptions that came from our departments. We are going to be converting to RHC status for 9 months of the fiscal year. I'm hoping that that pans out. There may waggle into that 8th month, but we'll see here. The revenue assumptions there are based on, I think, very solid assumptions that came from the Edie Bailey conversation I think you had 2 months ago. And so we used that to build the revenue assumption there, but we think there's some benefits that are going to be coming from that. Obviously, the sooner the better. We're not projecting any price increases. Our charges are not going to increase this year, nor are we expecting any big increases from our managed care payers. The only change that we may see is once we finalize that cost report, we will be communicating with our Medicare Advantage plans. The Medicare Advantage plans will have to pay us based on that per diem or that per discharge rate that comes from our cost report. So we may be making some switches there, but that's really the only material switch that will, significant switch that we can see happening in those revenue assumptions. We do see a decrease in allowances because with the critical access hospital designation of being paid based on cost, that's a much more favorable pay rate for us. That is also reflected in some of the adjustments I talked about earlier. The other end, cafeteria sales being shot pretty much flat from last year. Obviously, it'll tick up just a little bit with the additional activity we're going to see around the campuses. Retail pharmacies being added for long-term care. So that's all on the revenue side, the operating revenue side of the equation. We'll be happy to entertain any questions before I dive deeper.
Sounds great.
Then if we go next slide, we'll talk about operating expenses. 198 budgeted FTEs. We currently have 190 filled. New positions, including CFO, some nursing positions in particular, and also coding health. There's a 1% wage increase that you see here, all pretty straightforward. The benefit charge follows in lockstep with payroll. The normal sort of mode of operation for budgeting this item within a budget is we take a percentage of the salary, wages, and benefits, take a assumed percentage on that, layer it on top, that becomes the benefit charge. So really, that's what you're seeing there is the sort of linear increase that you'll see in the salaries and wages. Benefits are going to track right along with it. They don't track up quite as quickly because of the change we talked about with the self-funded employee insurance plan. We do think that at the start off, we're not going to see great savings. They're going to come toward the later end of the year. We're actually going to look at that staying fairly static this year. We may get some, unexpected benefits there. So we're trying to stay conservative. We're also reflecting an increase in the YMU returning contribution. Everything else really straightforward. All right, let's move down further into the expenses. You'll follow the blue bar is going to drop down just a little bit. And I'm going to talk about the next items. Next slide. Yeah. There we go. Okay. Professional fees. Really, the reduction is coming from transitioning away from the health tech contracts to district employees here. So that's the big change that you'll see in the professional fees. We do see some reduction in the local tenants and contract positions. We are going to have one contract in place. It's still fairly sizable. Supplies, we do think.
I think that one took in the apogee reduction too, right?
Yes.
Yeah, so that was significant.
Supply expense, obviously, we expect some benefits from the Medline relationship that Dominic talked about earlier. It wouldn't surprise me that we see a better savings from that, but I think once we're actually up and going on that, we'll see those savings downstream. Net, we expect that to be about 1.25 points. And then maintenance and repairs, as I mentioned before, we've got a lot of maintenance contracts out there. And really, I think it's an important investment that I would advocate for on behalf of management to the board that we follow that, that we get those maintenance contracts in place to take good care of this new equipment. Really make sure that we're able to realize the full useful life of those items because of, as Rex said, when we talked about the cash collection rules. Right now, it's going to be challenging for us to replace those items. So the best thing we can do is keep them running, get them out to the maximum useful life. So I really will advocate that those maintenance expenses are a good investment on behalf of the district. Let's go to the next slide. Okay, everything else. Interest expense, obviously, with the closure of the loan, taking care of those things. The interest rates or interest expense is going to be changing. Contract labor, we do expect that to come down. We have our Chief Human Resources Officer that's on point with that task, and we do believe we're going to see some improvement with some of the strategies that Rex has talked about with trying to harvest the local nursing graduates, trying to bring some people back into the fold, if you will. There's a great opportunity there. It's really low-hanging fruit. Purchase services, they're going to increase really because of adding the senior life solutions and the wound care, but that's going to pencil out to have a positive impact on the organization. So again, I would advocate they're going to be positive investments on behalf of this district. Leases and rentals, increased rental equipment, certainly. The vendors, though, they're not quite as, shall we say, magnanimous as we are in terms of not making price increases. So the rental expenses that you're seeing there reflective basically of vendor pass-through inflation. Depreciation, obviously, you're going to see a big swing there, but that is the full year impact of depreciating the building. I'm done with expenses. I'd be happy to address any questions before I wrap up. Okay, here is your. Oh, I'm sorry.
No, you said it's pretty straightforward.
Okay. All right, well, let's wrap up with non-operating revenues. The mill levy income, was projected to be about 14%. Or a lot of the words out there saying it would be about 14%. We've dialed that back just a bit, and we're going to bank on a 10% increase year over year. Again, we hope that we'll have some good news to report to the board going forward, but we would prefer to under-promise and over-deliver at this point. Donations, you see the sources there, foundation activity, obviously very critical to us. And then there is the rural Sunrise grants. We've already talked about that, and nothing else to really add there. I want to talk about the rural transformation grants. All right, $205 million out there. We have really taken a very conservative position here on this. There have been some great ideas put out here. We talked about what we think is going to be a good amount of money coming. I've always said in trust and verify. We'll trust it's going to come, but I'm not convinced that that money is going to show up when we think it's going to show up, in the amount it's going to show up. My experience in Colorado has been that a lot of those promises are made around those grants, and then something gets dialed back. So again, in the interest of that mantra I just mentioned, under promise, over deliver, you see we're putting about $250,000 on the books for the budget for next year. I would be greatly surprised if we don't beat that number, but I would rather we build our operations around something that we're very confident is going to happen. And certainly we don't know until those funds actually are awarded and when they actually hit the bank account, because that's when we're really going to be able to say hooray. So that's my story. Let's go to this overview and I'll wrap up. So overall, you're going to see net operating revenues of a little bit more than $30 million, and we're projecting an operating loss of about $10 million. Now, that is a slight, I'm sorry, that's an improvement. You see, we're going to have an operating.
It's a significant improvement.
Yes. And a lot of it comes on the operating revenues and some of the things we're going to be able to do with expenses. The good news that I want to talk about comes a little further down the page there, right? The net income you see is going to have a very significant, about a $9.7 favorable swing year to year. But we're still losing money. And that's the rough part of it. But I think it's very exciting for the board to look at the EBITDA number. Earnings before interest, depreciation, and amortization. Yeah. Those last four letters, the last two letters, depreciation and amortization, we don't write a check for that. It's a non-cash expense. And so it's important for us to say, we're going to project that we're going to bring in about $3.5 million in cash next year. If you compare that with last year, where an additional $2.3 million went out, that's a notable swing. And I think it's really a credit to the team that that's been assembled here that's going to be able to make that happen. Madam Chair, I'm going to shut up and address any questions that you have.
Well, that EBITDA number is what USDA is obviously concerned about.
Yes.
Right.
Or has
That's our
been
ability to
concerned
pay
about.
bills.
And I know one weekend I was playing with the numbers, and certainly, I mean, again, these are conservative. I mean, we have 198 FTEs. I think we can get down to 190. We're definitely not. I mean, we can do that through attrition and combining duties once we have a better feel for who's doing what. Kind of back to your question about staffing. So I think we'll end up, probably 8 FTEs down at the end of the fiscal year. But we're really conservative on the contractuals. I mean, now that we are a critical access hospital, and I just want the board to know we haven't given up on why those contractuals were so high previously, because those were incredibly high numbers, even as a PPS hospital. So we're still researching that to find out what happened and why, and was it right. But I'm kind of like Jeff. I just like Michelle's done an incredibly good job. I was really pleased to get here and find out that the department heads were all involved in it, and it all kind of percolated up the numbers. And then Jeff came and used his wisdom and expertise from years of doing this and his access to data to fine tune it anymore. It's, I think, a really, really good budget.
Yeah.
And one that we will drive our behavior, and we certainly will use it to celebrate accomplishments by departments, and departments that are not, are falling a little bit behind. We'll use it as education and opportunity maybe to make, make adjustments, or if nothing else, have answers for the board when we bring you our reports. So anyhow, I think well done.
I appreciate it. Just one comment and one question from me, if you don't mind. In the comment, thank you for taking a conservative approach. I appreciate that. I think it's the best way for us to approach that, especially in the time we're in. So thank you. Secondly, I know that we are focused on EBITDA, and we're kind of learning that transition, but my request would be, moving forward, along with the balance sheet, could we have days cash on hand? As well.
Absolutely.
Yeah, no,
That's just a good,
that's a really good.
quick measure for us to be able to go, okay, where are we at here in operating?
Can you add that to your key performance indicator?
If we could have that in those materials, I would be very appreciative.
You just made my heart flutter with joy.
Yeah, me too. Me too. That makes me very happy.
Okay, I'm glad I could make something happen.
Yeah, days cash is critically important. I mean, people look at it in different ways, and some look at it as it's just a number, but it's not just a number. It's a really, really important indicator, and it's the same thing on the other side with regards to AR days. I know earlier on Rex and Jeff spoke about we had 160 wanting to get down to 40, but initially getting down to like 80 days. I think that as a target, and we should try and determine when that target month should be. I think even getting to 60 or 65 would be a great achievement as a goal right now.
I would absolutely agree with
And
you.
the only other piece that's important, I think, from a board and our administration perspective, is the aging of accounts
Yes.
payable,
Yeah.
because that affects cash. So, and we need to start tracking that too.
That's one of the things I was going to offer up. I'd love to offer to the board that we put together sort of a dashboard of financial metrics, financial ratios, such as the days cash on hand, which is obviously critical. It's what I live and breathe on. But to give you some of those other metrics around the bigger piece of the business. And if you'd be willing to take a look at us sharing something like that with you, and then I'd be happy to come in and do my college professor thing and talk about what these ratios mean if you like. But I think that would be great for the board to see that visibility into really what's under the hood of the business financial.
Yeah, we definitely want to be totally transparent with the board and the community and all of our employees with this. And that's part of the all staff meetings, to share that information with them as well.
Yeah. I would be very appreciative. I think just the brief snapshot helps us in going through all of our numbers every month and really understanding where we're at.
So, Jeff, I wanted to ask you: Are you getting the daily CEO dashboard?
No, sir, I'm not.
You're not getting it yet?
No, you're not. I need to get that out. That's on me. So I don't know.
No.
Leave it with me, because I think a lot of what you are talking about, we are automatically getting that out of the daily dashboard from the enterprise data warehouse. So let me make sure that you start receiving that every single morning. And then the other thing that I also wanted to mention is, we've been trying to and wanting to get the financial statement set up on our Optimum platform. And as soon as we can get to a point where we can actually do that, then I think the board will really get a lot out of it, because on the Optimum financial platform, it shows benchmarks as well. So you can see where you're trending versus versus the benchmark ratios. So I think as soon as, in some cases, the Optimum platform that we have with regards to presenting the financial statements is a little bit overcomplicated, but we can simplify it, and I can get Mark or John to take the board through how to read it. But everything that you're talking about right now, we have for you, and we can make sure you have it. You don't need to build anything new, Jeff. We have it.
Hear that.
One more question.
Yes, ma'am.
Just came to my mind. This budget as presented to us, and I think we talked about this a little bit last month, so it was before you arrived, Jeff, but it doesn't make any assumptions for our line of credit. And how do we address that in our final budget that we present?
I don't know the answer to that.
Okay.
I do know the only interaction with the line of credit is with respect to that interest expense.
Yeah.
Anything else in terms of like the pay down or pay back to that actually would not be in the income statement anyway, but it would be reflected in the cash, the cash flows
Okay,
that you would see as you look at the balance sheet. And certainly as we talk about some of the financial ratios that we demonstrate, you'll see those changes in balances. So it wouldn't actually come up in this statement either way.
okay, but the interest assumptions are in. here,
Yes,
correct?
yes, ma'am.
Okay,
That's
thank
correct.
you. I just wanted to clarify that. Thank you.
And I have a question along those lines as well.
Yes.
So in our resolution that just has kind of the summary lines for each item of the budget,
Yes,
it has added to reserves as a negative 3.5 million.
that, Yeah.
So my question is, where is that 3.5 million going to come from?
actually, I'm not sure why it's being reflected as a negative number. I think that's just a change on the way that's being depicted on the memo. But because actually we should be adding 3.5 million to the reserves. So we wouldn't be taking 3.5 out of anything, it would be a negative deduction to the reserves. We're actually planning to put $3.5 million back into those
Into
reserves.
reserves. Okay. Is that accurate then, how that's?
What balances community expenses and revenues, that's the way they balance. Because we have more revenues than expenses, so the difference goes to reserves.
I'm not sure why it
And
came
if
out
you're
there.
adding to reserves and it's a negative number, then that's very confusing. I mean, I see what, I see what you're saying by
Yeah.
having the balance, but
Right.
to me, like. I mean, because if that's the case, and that's what makes it balanced, then that's
Yeah.
$3.5 million.
I think what that is, I see what that is now.
No, it's the revenue.
I have to read into it.
Number 10.
That is actually a negative revenue. Right, because the report there is grouped by expenses at the top, revenues at the bottom. Sorry, I should probably use my phone to guess out there. And the $3.5 million is actually a reduction in revenue. We have more revenues from all of the other lines above that to cover the expenses.
Does that make sense?
It's not necessarily showing as a negative.
Yeah.
Okay.
It really reflects our profit.
Okay.
We have that much more revenue than we need.
That's called healthcare accounting. Or at least that's what CFOs use, negatives and positives, it's whatever.
For 3 years, get a doctor. So. Does that help?
Yes, thank you.
Any other questions from the group? Let's stop for that.
Jeff, I have one question.
Yes, sir.
Budget report, you indicated, went along with the assumption that we would get the RHC designation for 9 months in the next fiscal year.
Yes.
What kind of impact would that be on the budget if in fact we only had it for 6 months in the next fiscal year? And I asked that question because in previous conversations with the interim CEO, that was his projection that we talked about. It would take us to at least January to get that designation. So I just wondered how much of an impact that has on the budget.
And I wouldn't disagree with that prior CEO's view. It very well could be that way. The projection that I put in here was about $700,000 for the year. So if we just say roughly $70,000 a month for every month we push back, we lose.
Well, and that's actually understated too. I'm glad you did it that way, but the I Bailey was about $900,000 improvement.
Yes.
So if it's 6 months, it'd be 450. So we were conservative, but we are fast tracking it. I know accountants like to move at a certain pace, and this is about exceeding the pace I Bailey likes to move, but we are moving quickly. So hopefully we can have it up and running. Whether it's 90 days or 120 days, I think within that range we'll be up and running.
Thank you.
Good question.
Thanks for the discussion. It's good discussion. Hopefully we won't be having to make any amendments next year. So,
Do you have to make them if it's positive?
I don't believe so, only if
Okay,
it's
just if
negative,
it's
to my
negative.
knowledge.
We may just do it if it's positive, just
Just to-
just to do it.
Isn't that nice? Okay,
Well done.
given all that discussion, we do have a resolution that we need to take action on as a board, so. Is everyone prepared to approve this budget and finality this evening? Okay. Would you like to make a motion?
Sure. Madam Chair, I move to approve the final budget resolution number 10-26.
Okay, thank you, Kendra. We have a motion.
Madam Chair, I'll second.
And a second. Thank you. Are there any other questions? Last minute discussion, questions, concerns? Okay. All in favor of the motion to approve resolution of intent number 10-2026 regarding our final budget, please say aye. 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 No one opposed, so motion carries. All right, thank you. Appreciate the information and all the work on this. I know that a significant amount of work has gone into the preparation, so thanks to all of you involved. Next item on the agenda is transfer from construction account resolution. We've got one more resolution here. Don't have that. We don't have a resolution. Yeah, we do not have a resolution. I know that was a rapid add yesterday and I did not realize this morning that
I
resolution.
wonder if I added it and didn't publish after I added. Let me go. I'm in diligent right now. Just a second. Well, it's my guess. My screen's taking over, Rex.
So this would be a transfer of monies from the construction account back to operating account, correct? Reflected by $5,000, my understanding.
Yes.
Sure enough, guys.
Do you have the resolution anywhere?
Yep.
Can you email it to us real quick or something?
Just a second. Just give me a second here. Well, I need to unshare my screen so everyone doesn't see what I'm
How about we skip ahead and we'll come back to that in just a moment, Jen? Would
Yep.
that be helpful?
for some reason, I don't know why you're sharing and I'm sharing. That's baffling me.
Jan, if it helps you, I do not see your screen on Zoom.
Ah, fantastic. Okay. Everybody else will just keep quiet while I'm moving screens along. Yeah. So,
We'll move forward and just let me know when you're ready to come back.
Want us to put the camera on you while you're.
no.
Oh, let me forget. Back to, okay. The next item is appointment for board vacancy, which we need to have some further discussion in executive, so we'll come back to that action item after executive session. Which puts us at Senior Life Solutions presentation. So Kirby, I'll turn the time over to you and just go through your presentation to the board.
Good evening, how are you guys?
Great. Thanks for being here.
Slide deck.
I do. Just say next slide, please.
Well, next slide, please. I'll do my intro. I'm Kirby. Thank you for getting me before the meeting. I'm from Minnesota. Like I said, I'm like Rex a little bit. I'm a CEO of Critical Access Hospital Wanderer. I ran hospitals in Montana, Iowa, Minnesota, most of the upper Midwest. I've worked in systems. I worked for Sanford Health out of Sioux Falls, South Dakota. And I also ran a couple of critical access hospitals for Mayo Clinic in Minnesota. So I've been around cost reports, rural health clinics, 340B, when I was looking at Rex's data on the income statement, the balance sheet. I asked him a few questions. He's like, Kirby, We got 340B roll off clinic in the swim band program ready to go. And that just gave me so much confidence because we all have our playbook of how to execute critical access hospital operations. And obviously Rex has been doing it a long time, and Jeff is also very well versed. I actually got my MHA from the University of Colorado in Denver. So I'm a buff by trade, 2016 to it actually. But yeah, I live in Minnesota. I've been working in rural medicine my whole life. My brother's a critical access hospital CFO and has been for 25 years. So any of the EBITDA or days cash or days in accounts receivable questions, I always have a CFO on speed dial to give a good insight. But I'm here on behalf of Senior Life Solutions. So Rex is the most well-versed hospital administrator I've ever gotten a chance to work with. Typically, it's me educating the administration, the board, about the values of Senior Life Solutions. And Rex cut me off at almost every turn and said, no, I've implemented this program a bunch of times. You know, and he would
Changes lives.
tell me stories about life-changing experiences and conversations he's had with patients that have gone through the program. He said, I know it's going to be a perfect fit for Pinedale and Sublette County. And so we've been working through the space exercise to look for space that would be a value add to the aesthetic of that patient population. And so I think we have a good plan, and I'm super excited to talk a little bit more about the operational detail, the program value. Next slide, Rex. Next slide. So it's called Senior Life Solutions. I actually got the opportunity as a hospital CEO in Bloomfield, Iowa, 10 years ago now, to implement my own Senior Life Solutions program at my critical access hospital as the administrator. So I also have gotten to experience it firsthand like Rex, and that's why I'm passionate about the program, the company, and the reach it creates for rural medicine. As you guys can imagine, rural patients are the most underserved, underdiagnosed psychiatric population. And that it's even worse in Wyoming and Montana, if you look at the data in terms of psychiatric providers per population. And you can't necessarily get services if providers aren't available to you. And so the company has been around for over 20 years. We started with one critical access hospital in rural Tennessee. And over the past 20 years, we have current partnerships with 186. I need to update my slide. 186 critical access hospitals from our program. Just in the last 9 months, I've signed 5 critical access hospitals up in the state of Montana. I think a lot of the CEOs up there got their community health needs assessments back, which you guys will do, which is great. And I think at that point, not only their 2025 CHNAs, but their 2022s, their 2019s, their 2015s, all had mental health as a top priority, where their patients and their counties were filling out, we don't do enough for mental health. We don't do enough for mental health. And I think the board's got overwhelmed and sick of seeing it as the top priority in every single survey they sent out. And finally, I think a bunch of the CEOs were saying, we have to do something better locally. You know, because the classic conundrum is, do we do mental health locally or do we just send it somewhere else? And some of these places in Wyoming and Montana are really far away from that next psychiatrist, that next social worker. So I'll be excited to read the first iteration of the Sublette County Community Health Needs Assessment. I'm presenting to Thermopolis's board next Tuesday. I just had a call with Scott Alwyn, their CEO, Monday of this week. And I have screenshots of 4 of his community health needs assessments in a row over a 12-year period of time. And mental health is in the top 1 or 2 on every single one. I think I'll actually get to meet Dominic potentially at that one too. So that's
yes,
nice.
I will be at that meeting. Looking forward to that.
Sounds good. Next slide, please. So Senior Life Solutions, it's a program we put only in rural places. We only work with critical access hospitals because the model of care is based on a rural environment. We don't work with PPS or tertiary care facilities that have inpatient psych units or psychiatric hospitals in themselves. We want to provide access locally to the patients of Sublette County so that they don't have to drive to Salt Lake City or somewhere further away. we measure our outcomes of our patients when they get to us and then when they leave from our program. We report that back to the board and the medical staff. So key players, stakeholders will be able to see the clinical value improvements our patients are making. And then the goal too is to reduce the cycle of mental health. And I don't know if you guys know people who have had mental health issues or mental health symptoms, but typically it's emergency room visit, transfer to an inpatient psychiatric facility. Do you guys know where the closest one is to Sublette County?
Jackson.
And so then they go there for 72 hours or a few weeks, but they're always going to come home. This is where they live. And so if we can create access points in our rural communities, we can keep patients out of that cycle because it's hard on patients, it's hard on the families. And at the end of the day, they're always going to come home. So let's keep them close to home in an outpatient environment that creates safety and security for them. Because I don't think an inpatient psych facility is where anybody wants to be, especially in their later years of life. That's an incredibly scary experience. So one of our main value propositions is keeping patients on an outpatient basis rather than an inpatient psychiatric 24/7 box on the outside of the doors environment. The value for the critical access hospital addresses community need and mission. I'll bet each one of you $1 right now. Mental health will be on the top priority list of your first CHMA, and I'm sure we'll have that conversation at some point. But in improving the holistic whole picture of care, obviously the medical staff gets to see the patients in your local clinics here in town and up in Pinedale. And a lot of them are dealing with mental health conversations every day. They're not scheduling the visit because of a psychiatric symptom, but ultimately the visits turn into conversations about their mental health, about their behavioral health challenges, about new symptoms, especially later on in life that are occurring once they've lost their spouse, they've potentially lost a child, maybe it's a terminal illness. That can have a crazy impact on somebody's life or their spouse's life, because at the moment you get that diagnosis, your life is changed. And so the breadth of patients we serve, and we work really closely with the primary care providers. One of the nice things about our model is we'll be using your electronic medical records. So everything that's going on within our intensive outpatient program, the providers will have at their fingertips before their primary care visits, Medicare annual wellness visits. So it's available to everyone, even the hospitalists. If somebody gets admitted into a swing bed or a med surge or an emergency visit, which we hope doesn't happen. But it sometimes does, of course. Next slide, please. 50% of my partners are affiliated with the health system, and 50% of my partners are completely independent, like Sublette County. We have 185, we're in 32 states. I get to cover the upper Midwest where I live and where I've operated hospitals in my career. So I have Wyoming, Montana, North Dakota, South Dakota, and Minnesota. Those are my most familiar landscapes. So that's where I get to be. Next slide, please. It's not an inpatient unit. When I say intensive outpatient psychiatry, don't imagine it being opening an inpatient unit here. Our patients don't stay overnight. They're not there for 24 hours a day. Intensive outpatient programming. Once we got big enough as a firm, Medicare actually categorized it as a specific type of psychotherapy, where we see our patients multiple times a week. In a typical outpatient psychiatric practice, you'd see your provider once a week. If it's a therapist, once a month or once a quarter. If it's a provider like a nurse practitioner or a physician, our team will see our patients oftentimes 2, 3, even sometimes 4 days a week. These patients have a little more intensity. These are patients who, if they didn't have SLS, they might be in an inpatient psychiatric unit. And so we want to keep them out of that cycle. I think a couple hours a day, 3 days a week is much better than a 24/7 locked unit in so many different categories of the patient's lives. But I just wanted to reiterate to the board, it's not an inpatient psychiatric unit you'd be running. Next slide, please. This is a management services arrangement. So you guys wouldn't go out and hire a bunch of people to run this brand new psychiatric outpatient model. We employ the people, we manage the people, we credential the people, we supervise the people, we license the people. This is all we do. We're a psychiatric rural company. And so, smart CEOs like Rex have the gall to say, we're not experts in mental health, we're not experts in psychiatry. Let's work with somebody who's familiar, experienced, and a subject matter expert in this model. So we run the program. Our psychiatrists are the medical director of the program. So our psychiatrists will be supervising the staff, ensuring patient care is up to industry standard and in the mental health industry. We evaluate and diagnose all of our patients. Reducing pharmaceutical use, especially for narcotics or opioids, is a big part of our mission as a company. I can tell you story after story of how many patients come to Senior Life Solutions, obviously in other communities, and they're on a dozen different medications from half a dozen providers, and none of these providers know about each other. That's a dangerous cocktail. And so we try and get a strategic polypharm strategy for each patient to make sure they're taking the least amount of medication possible, but the right meds with the diagnosis that they have. So that's a big part of what our psychiatrist does as the care team leader. We measure outcomes, and we use industry standard measurement tools, and then we'll report that back to the board, the leadership and Rex, and then the medical staff on clinical improvements in both major depression and anxiety categories for mental health. If there are other measurement KPIs, the med staff or Rex's team wants us to use, we have some partners who ask us to use something else, and we just adopt those. But the goal is to reduce institutionalization, hospitalization, keep patients out of your emergency room. That's a scary place because your providers and your EDs, like ED up in Pineville, they don't see psychiatry patients every day. So it's unfamiliar for them. So if we can keep those types of patients out of the emergency room, that's great. A lot of boarding conversations I'm hearing from Wyoming-based CEOs of, oh yeah, we had a patient in the emergency room for 7 days because we couldn't find an inpatient bed available. Nobody belongs in an emergency room for 7 days. That's not safe. So the goal is to keep them out of that environment as much as possible. Next slide, please. Just a couple of facts for the board. Patients over 65 only make up a little over 10% of the population, but account for more than 20% of suicides, especially in rural environments. Isolation and loneliness can be a huge contributing factor to alcohol abuse, opioid abuse, taking one's own life. And so the goal is to have a program that can provide some relief for these patients who are struggling. I often ask boards, can you think of somebody in the community that oftentimes lies on the negative side of life? Oh, the county's doing this. Oh, the city council's doing that. Oh, the schools are doing this. Think if that person you're thinking about has a change of heart, a change of life circumstance, and becomes a positive contributing member of society. Those stories happen with SLS, and then those patients are the best marketers in the world. You know, we can work on a website and pamphlets to the kilter, but if somebody tells their story and everybody knows that person, like, oh my gosh, if Jeff could turn it around, I mean, imagine what it could do. And so after the first 6 to 9 months, we typically start the word of mouth marketing, testimonials, and it's amazing for the reputation and perception from the community of why the program is in place and what impact it can have. Next slide, please. One of the cool things about our program, guys, is that our staff provide transportation to any patient within 30 to 35 miles of Pineville. So whether they're here or whether they're somewhere towards Jackson, if they can't get themselves to the hospital to go to group or go to their individual psychotherapy appointments, we're going to go pick them up. Transportation is a huge barrier to psych care. I'm sure you know what your cancellation no-show rates are in your primary care practice. Double it for mental health. And so we want to remove that barrier as a reason not to go to their appointments. So our staff actually drive and pick patients up, whether it's from a skilled nursing facility, their own home, a senior center, wherever they need us to be, that's where we go to make sure they contribute to the group. We recruit all of our own staff. We sign in our partnerships, Raymond, don't worry, that we'll never employ or recruit a current Sublette County Health employee. We understand how hard it is to keep people and to get people, especially when you have travelers on site already. We don't want to force you to have another one by employing your best RN or your only social worker. So we recruit our own people with our own team. We manage them. We adopt all of the Sublette County policies and procedures. So we do things the Sublette County way. We ingrain our staff into the culture. We often send our staff through new employee orientation at our partners' hospitals, so they know exactly what to expect of their performance, of their interaction with patients, of their staff members. We basically become another department in the hospital. I'd say over 90% of our staff wear the hospital badges on their uniforms, and we follow the uniform policy just like everybody else. There's no real value in the patients knowing that the SLS staff work for us and you guys. So they do all their own documentation, all their own registration. We don't, as a good partner, try and overload tertiary departments of our service, whether it's the registration staff or any other pieces of the care spectrum. And then we also allocate 250 hours each year to be out in Sublette County and the surrounding region, marketing, engaging with potential patients, educating people on the importance of accessing behavioral health, early interventions. We'll be at the county fairs, we'll have a booth. Any health and wellness activities going on in the county or the region will be present. It's a part of our accountability to growing the program, not only reputationally, but also in terms of patient serve. So one thing to know about the program, the core service is called group psychotherapy. We cap it at 10 because can you imagine having a group psychotherapy session with like 75 people? So we cap it at 10, that's the industry best practice. And then our patients stay within the program for about 6 months. So don't look at this as a typical like new clinic service where you want to see like 2,000 patients per year. We're probably only going to serve in between 60 and 100 individual patients per year because of the length of stay and how we have to cap the program volumes to keep it successful. And so that's our goals, is to impact 75 to 85 lives a year. But if you think about the people that see the value in the program, it's their spouses, it's their kids, it's their friends and family. So the goal is to impact obviously way more than 75 individual patients per year. We measure outcomes. We do compliance audits. We provide our data for the cost report preparation process. Obviously, being in 186 cause, we're very familiar with conditions of participation put out by Medicare. So we keep our compliance and quality assurance pieces in place. We have people that do that for every program in the country. So it doesn't add the burden on to the compliance or quality department of our hospital partners. That's a big reason why we have those departments within the firm. Next slide, please. And the types of people. Our spectrum is wide of types of patients who approach Senior Life Solutions. It could be common depression, anxiety, panic attacks, memory problems. We see a lot of early stage Alzheimer's and dementia patients. That's a really hard time in life, not only for the patients themselves as they're exuding new symptoms, but the spouses as well. Current past substance abusers. It's a good program for them. Obviously, they can't be on a current substance while on group or while at their individual appointments, but we've dealt with a lot of MAT treatments, medically assisted treatments. So we're familiar with that protocol and those types of patients, but the spectrum is really wide on the types of patients. I met a gal who was in the SLS program in Bloomfield, and she said, my husband died. I said, that's to be really sad and hard. And she goes, no, it wasn't that. He paid all the bills. I'm a homemaker. I'm a cooker. I'm a laundry. I'm a cleaner. I thought they were going to turn my water off. She didn't know how to write a check. So our staff helped her write out the list of all the bills she needed to pay each month, the day they were due, taught her how to write a check, taught her how to job. That's what he did. He handled that piece of her life. So she was in severe anxiety status when she came to SLS saying, they're going to take my house. I haven't paid the mortgage. So lots of different reasons why patients get anxious or depressed or scared out there, and especially when they're alone. So next slide. I think Jeff mentioned, all of our costs are allowable on the cost report. Critical access hospital status was the reason why SLS is fiscally sustainable and valuable to the bottom line of the organization. And obviously in all of my new hospital partners that have a lot of depreciation, like you guys do, the net impact to the program is oftentimes much higher in environments with a lot of depreciation. I work with hospitals that have no depreciation because their hospital was built in 1957, and it seems harder to get a net impact that makes them feel. And so I'm pretty confident the Sublette County facility is going to have a pretty high number. But it takes 5 months from the board's approval and rec signing a partnership agreement to go from a blank slate to our implementation team completely starting a program from scratch in patients on day one. That's all I have. I want to leave time available to the board for questions. Rex knows the program really well. This has been an interesting conversation for me as he tells me somewhat more than I can explain because he's been there and done it. So it's been helpful too.
It doesn't generate a lot of, well, I mean, I think, I don't know, probably, I don't know, 12, 13%, I think, return on investment, you know, revenue over expenses, but it's the cost report where you have the biggest, you know, opportunity, I think. We did early on, I didn't think it was going to be possible because you have to be 250 yards. If you're going to be remote, you have to be 250 yards from the main campus. And so when we first did our Google search and stepped it off, we were 290 from the corner of the hospital down the hill to the Sublette corner of the Sublette Center. So we thought we could make a case. But then we went property line to property line, which I think you guys have checked out. We're 247 or something, so we're really close. So, and we have space. You can, it's allowed. Cost report allows up to 3,000 square feet. So, I mean, that's the maximum amount you can claim on your cost report, from what I understand. Someone's correct. And so we have space down in the Sublette Center, taking one of those dining rooms and some of the office areas or storage rooms where we get awfully close to 3,000. So. It's just, you know, if the board feels comfortable moving forward with that, I definitely should have done this earlier, but I text the lady that started it up in Sublette. She's outstanding. And I don't know, we had one lady in particular that came in and she was just negative as could be. By the end, she bought me a stand-up Santa and she said it's the, you know, the greatest program she's been part of. So regardless, as long as we cover costs, and we have the cost report advantage, those are great, but the big thing is it does change lives. And I think it also is kind of a platform into other behavioral health services. And I really would like to see us going forward, focus on that, maybe run the clinic, because a lot of what, you know, Dr. Burnett and providers deal with are people that are having behavioral health issues that are triggering, you know, physical issues. And it all kind of ties together. So, but this is a really good dip. Well, more than dip your toe, put your whole leg in the water and see if it works. And it does sell itself. And I think I shared in my interview, the guy that founded the swing bed program, his name is Kurt Erickson, and he just didn't, I mean, he lost his wife. I just moved there and he had changed obviously a lot in 20 years since I last saw him. He was with a walker and he was a robust guy and he freaked me out when he would talk to me when I worked for the company. But I would go see him before board meetings and he would just, we'd pull out the VHS tapes and we'd watch his retirement and his wife and his kids and he'd be bawling and I'd leave and I'd say, I think you can benefit from this program, Kurt. And he'd tell me, yes, I think I can, Rex, get me signed up. And then I'd walk in the next morning and my secretary, executive assistant was on the line. Kurt was yelling at me saying he wasn't crazy. He didn't need to be in the program. But finally, one day he didn't call me and we signed him up and got him in the program. And he told me before he passed away, I mean, he had given up and it gave him 3 more really good years with his grandkids, his great grandkids, his sons, and he had a zest for life. And so he'd come to board meetings and it made a difference. And that's when I became a believer because I'd let it sit on my desk for quite a while in Phillipsburg, Kansas. And the gentleman had moved into the, he's going to be hospital CEO in one of the smaller hospitals in the Northwest, but he had worked for these guys. And I thought, he was so gung ho on it, and I was helping him with some of his moving with the company I was working for, doing two jobs, but I thought we better get in this thing. If he's this bullish on it, it must be pretty good. So we signed it and it really started our turnaround as an organization. I mean, without that, community came back and one, supporting the hospital. I mean, people came in, the cost report first year was outstanding. And so it really was kind of the sand to get us traction to get moving again. So, but you guys should take time to think about it. We have a contract. I sent it to Lena to review. I mean, you're 5 months out. If you need another month to think about it and give more testimonies, I mean, obviously Kirby's done a great job. But I mean, if we did it in July, we would be ready to start the first of the year, or at least gear up in December, I think. So on this timetable, even though we've tried to speed it up, it's pretty much what it is. So.
Well, and I talked to my implementation director today. I'll be in this for board approval on Tuesday. I asked her if we start 2 Wyoming-based programs at the same time, can we work on a 4-month timeline if they want to start sooner? And she said, yes, because we've implemented 4 of these in 180-mile radius in Montana all at the same time. And they're seeing quick.
So
there's some economies of that. And so I would love to see Sublette and Hot Springs kind of go through the implementation, because I'm gonna use the same implementation director for both if you guys approve. But he's right. I wouldn't be doing this if I didn't get to see it firsthand as a hospital administrator, honestly. I remember talking to a really well-known rancher farmer, and he said he had bad eyes. And I said, that's gotta stink. He goes, no, they took my driver's license, Kirby. My identity, I've been a farmer since the day I was born. They took my driver's license, couldn't drive the truck, couldn't drive the tractor, couldn't bring my boys coffee in the morning. I didn't know I was on planet Earth trying to kill myself, because if I'm not farming, I'm not adding any value to the world. And I was like, oh my gosh, and he had just an immense turnaround in the program. And I think that day was kind of this can be an amazing thing for a lot of people.
Well, they provide really good training too. And we had taken, I know in my last place, we kind of handpicked our people. They weren't happy where they were at. We thought they had skill sets would be good in this program, and they provide really good training, and they're great ambassadors for the hospital.
Yeah, and anything I put on the slides, because it's kind of hard to quantify or qualify. Having 3 people fully focused on this population and being that outlet for the organization, ED provider could run down, chat with the staff, have us come down, talk to a patient in ED or on the hospital floor in the clinic. If he said, I got a patient who's using some really funny words they haven't used, and I know this guy for 20 years, am I coming down and just chatting with him for a sec? We're going to be there Monday through Friday, 8 to 5. It's a full service program. And so I think the availability of our team to help all the other departments, I think, is kind of unspoken or unquantifiable, let's say, but it happens a lot where they're like, oh, I had this patient in ED, I was kind of scared, but your psych RN came down and kind of had a chat with them and gave me some direction, maybe it's a medication advice or something. There's a lot of assistance and help you provide that we take accountability for, but I can't really put it on the slides that our entire team is going to be in every department of the hospital 24 hours a day. So
it's 3 people on site,
yeah,
3 live people.
the psychiatrist is the only part of the team that's not living and working in Sublette County, coming to the facility every day, just like all the other staff, to treat people. Psychiatry is too intimate to have it be virtual. There are companies out there that provide virtual options, especially in rural environments. Boomers are prideful, they're stubborn, and so it needs in-person people to make the difference we think it can.
So a master's prepared behavioral therapist, and there are people here, I think, that need that qualification that might be interested. And an office manager is usually, I don't know, nurse aide, somebody, the registration person, and then the program director is an RN usually, correct?
You don't even need me here.
No, I do need you.
Yes, he's right. Yes.
So those are
RN is a therapist, master's level therapist, and an office patient coordinator who's usually like a CMA. They do the transportation, logistics, documentation, rep cycle stuff, making appointments, calling patients to remind them of their impending appointment and pickup. They do a lot of the groundwork.
Yeah.
It seems like a phenomenal opportunity and kind of a
Are you gonna
no-brainer.
rain on our
Why
parade?
wouldn't
No, I'm,
you? But
I'm gonna put some sunshine. Madam Chair, if I may just address the board on one other item here. The space that he's talking about using for
That's
some of these
exactly right.
modalities is under our current model really just dead space. It's common area, if you will. We're gonna take those spaces and be able to convert them into revenue producing space, not so much from the fees that are generated, that's out there. But as was mentioned from the cost report perspective, we take space that we can't really seek reimbursement on, or it's reimbursed at a minimal level. We're able to really amp up the amount of space charges that we can seek reimbursement for under the cost report. None of that was reflected in the budget proposal I already gave you, but it really represents a great business opportunity to convert a hallway, I'm being a little sarcastic here, but to take space that otherwise isn't being used to produce revenues, and we can reduce reimbursements from it.
Big Timber, Montana closed a 14,000 square foot assisted living facility. Board told the CEO, "We got to do something valuable with this space. It can't sit here. We built this assisted living 30 years ago, and now we're closing it because it's losing us $1 million a year." Lewistown, Montana closed a 59,000 square foot skilled nursing facility. So I said, "Cody, you got to figure out what you're going to do with this to make it add value." Assisted living closed across the street. Abby Lotz is the CEO in Red Lodge, Montana. They needed that space in the community to add value. For facilities with unutilized, undocumented, allowable square footage on the cost report. That's why.
Well, it's 100% Medicare too, so I mean, it's 100% fully allocatable.
And what's the referral process like? And are there qualifications that patient has to meet aside from being Medicare?
Great question. So it's a non-physician referral program. You don't have to go see a psychiatrist to get a written order to go to SLS. It's a low entry program. You don't need to meet some specific requirement clinically to get in. You guys are gonna get stopped at the grocery store, at the football game on Friday, at church. Hey, mom's really struggling since dad passed. Tell me about that program. Just call the hospital, ask for SLS. We could be assessing them the next day. But we do get a lot of referrals from the providers.
Right.
And one thing we do in the first 3 months of the program, even sometimes before go live, we will travel within 60 to 80 miles around Pinedale, talk to every provider practice, every clinic, make sure they're aware why the hospital's doing it, who qualifies and who's a good fit for the program, and how to get in touch with us. That's our job. That's why you pay us to do the work. So we have a really strategic marketing plan that we co-brand with your guys' Sublette County marketing strategy. But we're going to be out there a lot. You know, you might be at events that you hear us speaking to. That's a part of our accountabilities and community engagement, community education. But the first 6 to 12 months, a lot of providers send us patients. Pastors send us patients. Bree sends us patients. Skilled nursing facility staff or administrators send us patients. It's amazing that you guys have a SNP and a memory care unit attached. It's going to be a great opportunity for some of those patients who are really struggling with that transition in life, the struggles with aging in place, just to walk down the hall or get bussed down the hill to a program like this. Baked in volume is always great. But it's you don't need a physician written order or referral to get in a program. People will stop you at church and ask you about it.
Madam Chair, I
Sounds
have one question and one comment. The comment would be, I wouldn't take your dad about being the number one on the list in terms of needs assessment. I wouldn't take that way. The question is, I think it's very interesting that you provide transportation within a 35-mile radius. But that 35-mile radius is just like the 300 feet problem that we have. Because if you go from one town to the other, it's just a shade under 36 miles. So is there leeway there?
Yeah.
Where there could be a central collecting point where it's seniors or whatever?
I think we made that decision
That you
too.
can provide transportation.
We make it together. Yeah, don't feel.
Whether they
bad.
come up to the clinic or the seniors. or
Yeah,
whatever.
so The last hospital I sent in Montana, the board said, extend it to 45. That community out there is a psych desert. We need to take care of that community. It's on the High Line in Montana. It's the most remote place like ever. And I agreed because it was important to serve that community. So if you guys have specific communities that you want us to reach and engage the community, just tell Rex to put it in.
We definitely would.
Yeah.
That's it's anywhere around there.
And I will tell you,
Transportation's So
I
difficult.
will tell you, and I'll just speak from an SOS CEO myself. I was shocked because after the first year of the program, one of the things I was wondering about was where people would come from to access this program. Because yeah, we'll pick people up 35, let's say 38 miles or whatever you guys want to draw the radius as. But if people can drive themselves, they can come from anywhere.
Right.
And I remember getting the list of zip codes of where our patients live. There was a gal who came to my program in Bloomfield, Iowa. She drove 81 miles one way, 3 days a week for 6 months.
Does
I
it,
was shocked.
does it have to be one site? I mean, is there an opportunity in one of our clinics?
No. So it's based on
What's that distance?
access hospital license.
Sorry. you know.
300 feet.
Yards. Great question.
Okay.
But I promise you, the providers in these clinics around your hospital, primary and secondary service area, they're gonna have the content, they're gonna have the information, they're gonna have the phone number, they're gonna have our business cards. They're gonna get calls from us on a quarterly or monthly basis saying, any patients that you think would benefit, we actively seek out referral sources, especially providers. And you guys, the providers in your clinic in Pineville and here in town, they have been quasi psychiatrists for 40 years. You have a primary care physician right there who probably has 30% of his true practice patient panel as mental health behavioral health patients.
On any given day. it can be-
Any given day.
Yeah.
And they meet Dr. Floyd, my chief of staff in Bloomfield, Iowa, before I implemented SLS. Came in, shut the door behind him, never a good sign. He goes, Kirby, you want to know why I went to primary care residency? I said, no. He goes, because I hate psychiatry. He goes, you are forcing me to be a psychiatrist. They log down my calendar every day. And I'm Googling what these psychotropic medications are because I'm not a psychiatrist. I'm Googling in the visit. I pride myself on being pretty well prepared, pretty well educated in what my patients' issues are. I'm Googling what these medications they're on are. And they're not in the EMR because these providers are all over the place. So to give the medical staff more resources is a huge benefit also that I cannot put on that slide.
Yeah. The huge need.
What do your staff look like? I mean, they come and live here? Do they rotate through and stay the week here? Like, how's that?
Our staff are our local staff. I think I live in Minnesota. Not a lot of people want to live in Minnesota for obviously November, December, January, February, March, and April. This is a beautiful place. And the fact that Raymond said in the last 3 to 6 months, I've seen an influx of people who want to work here. I could probably say this is one of the easier places throughout my Wyoming hospital partners I have that recruiting won't be as much of a challenge.
Here's a prediction. They're all three already here.
Sex did call me and tell me he thinks that the staff are already here. But our team of recruiters, all they do, we have 6 of them. All they do 40 hours a week, 2 weeks a year, is find people who want to work in rural medicine in mental health. So I have uber confidence in us being able to find people if Rex is wrong and the staff aren't already here. And like I said, we do put in the partnership. We'll never recruiters steal your people. That's a promise we need to make to be a good partner. I mean, think of every hospital I went into, we just plucked the 3 best staff to understand. Wouldn't go over very well, so.
I can't for the life of me imagine why a critical access hospital wouldn't implement this program.
Well, I've only been doing this for a little under 3 years and I've signed like 38 of these partnerships. I just gotta talk about it, express the value, financial impact, the community benefit. I mean, every community health needs assessment I've looked at from all my Wyoming partners is, oh, alcohol, substance abuse, depression, anxiety, isolation, it's all there. So I can already probably guess what your top three priorities are gonna be when you guys do yours. I'd love for your approval and to get you to say yes, because it's a cool program. I wouldn't be doing it if it wasn't. Any other questions?
Well, Kirby, I will say that I can't speak on behalf of the board of Hot Springs, but I can tell you there's about 99% chance of them signing this up. I've already spoken to the board chair and as well as Scott. So,
Oh, good.
I think it's a fantastic program. I'm so glad Jeff pointed out what he pointed out, because it's not to make money. It's a service to the community, a very, very valuable and highly needed service to the community, but it's a great advantage to the cost report.
And Dominic probably has prior experience too. I've been partners with Taylor Rose, the CEO up in Barrett, Montana.
Yes.
For going on 3 years now. That program's been really successful when the community, it's really south. And so the community needed access points that south. It's
Yes.
just too far. There's Bozeman, Missoula, and all that. So that program's doing really well. So Taylor's been a great partner, and that's a help thing. So.
Yep. Good to hear.
Where would they go for training?
So what we do is after we hire them,
Because our goal would be a training site at some point in time if we move forward.
that'd be great.
Okay.
Yeah, it'd be nice to have one this far west. So what we do after we hire them and before they start, we send them to a really tenured, successful, they need to meet certain KPIs to be an SLS training site. We'll send them there for a week and they will see how a successful SLS program operates, evaluates itself, communicates with med staffs, referral sources, documents on patient care, make sure the rev cycle stuff is incredibly prioritized. We also do a really thorough prior authorization process to make sure all the insurances and copays and deductibles are covered. We don't want to leave any revenue for our hospital partners on the table at all. And so they will train for an entire week at a super site. And it'd be nice to have one this far west. Before I started, between Minnesota, North Dakota, South Dakota, Wyoming, and Montana, there's only one SLS program, and now there's like 39. And so we don't have a super site this far west. I think Dickinson might become one. They won program of the year last year, so I was kind of proud of that.
Do you have a question
I
to?
think I have one more probably for Rex for the space that we would implement this. Does it need renovation or is it kind of good as?
No, I mean, I think we put some paint on it. I mean, we haven't really decided which dining room it would be there, but probably the one as you come in the front, because I mean, there is, I think strategically, it's nice to have parking where it's not identified that that's what the parking is for. So then it would be easy for them to get in, but not much more than paint. And you've looked at the area, I think, when I last time.
Yeah, there's more furniture in that building, guys, than you can even sell a garage.
But we would
So,
spruce it up.
But I always say is, I'll let you paint the walls. Don't spend a bunch of money on SLS. Let us get through that first year. Let us make our financial impact to the bottom line of the organization, carry our weight. And if you want to spruce it up with some money, feel free. But you don't need to allocate 10K to the budget for renovations of any space down there. There's 7 spaces down there that are perfectly aesthetically viable for an intensive outpatient psychiatry program.
Okay, this is the last, or at least my question is, do we get the Rex Walk deferred fee deal?
Yes.
Okay, good. So what they've done in other places is they defer the costs and startup costs until we file a cost report. So at least we have revenue coming in to cover that. And I think, well, it should sync up okay, right?
Oh, it'll sync up wonderfully. Yeah. So if we go live, because your fiscal end is. Right.
So we'd have a half a year, so it'd work.
Yeah, it would work perfectly. We just don't want there to be any costs in the non-operating SLS year because it's not, it wouldn't be recognized by Medicare as fully allowable. So any costs that we would incur during the implementation phase, I'm just going to hold it until we're ready.
So you're asking for our approval to move forward with.
Well, if you're comfortable for it, I think Kirby's more, I mean, anxious to get started. I didn't realize that, there's another program, there might be some advantages. I want you to be comfortable with it. I mean, I've had the advantage of being involved with it, 2 other places, and I know it works, but it's important for you guys to be on board. And if we do it, I mean, our goal would be the top SLS program, at least in this part of the region. We want to do it right. But you guys have to be comfortable that this is what you want to move forward to, but it, cost report, I mean, from a critical access status program that Dominique's brought up, Jeff's brought up. I mean, it makes a lot of sense. It's just one of those things to add, and I think, for me personally, it gives us an opportunity to see if we can do more behavioral health, because I mean, it will be one of the top 5 things on our community needs assessment. And I just know in Springfield, I mean, there was a lot of depression there in Colorado. I mean, when I left, they were at a point a year into the program, they thought we had budgeted. We thought we'd have 2 patients, then 4 patients, and then 6 patients. We had 6 from the get-go, and we were maxed out before I left and looking at a dual, what do you call it, a dual side?
A second track.
Yeah, so
I'll tell you,
there's just a need in most small communities.
Lucenden's gonna be competitive, our program in Buffalo. He called me like last Thursday. He's like, we're almost at 10 patients. Get ready for that second track. There's more financial benefit to running a second track. And he's like, we're almost there. So he's a competitive dude, so.
We like our chances here.
Okay, all right. I like you both, so it's a win-win for me. But I love you guys' approval.
But you make it, if you're comfortable doing it, I mean, we can provide more information, bring more testimonials in. It's whatever you're comfortable with as board members.
I think I'm just looking for some clarification that you want us to approve you're moving forward with contracting tonight. And then you'll bring us the final contract
Right.
and all the numbers and everything for.
Yeah, we have the final contract. I mean, we have a contract. Lena, I sent it to her, I mean, she's only had a day or so to look at it. So, but, she has a contract and then we can certainly bring it back. And, for formal approval next month, if that's what you deem best.
We can show you Dom's.
And we can play catch up Kirby on it a little bit, I think, too. I mean, if they're looking on it with good favor, we just need to make sure we get the contract right.
Well, yeah, thoughts, agreement.
I think that sounds great. Absolutely.
Would we like to make a formal motion? I think it would be good to make a formal motion, take action to move forward in some way if the board, I would desire to do so.
I would be happy to make that motion. If you're ready. Move to approve moving forward with the Senior Life Solutions Program. Needs to be contingent on approval, contract review and approval.
How's that?
That work?
Creative. Okay, we have a motion and a second. Thank you. Any further questions for Kirby or for Rex before we take the final vote? Okay, all those in favor of the motion as stated, then please say aye. 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 One to oppose,
I
so.
get a lot of positive feedback in the community for this, I think.
I
Members.
think it sounds like I know there's such a need, so.
Last thing I will say, just for the record and for people on Zoom, I've been in a lot of critical access hospitals. Sublette County Health is the prettiest, most beautiful rural hospital I've ever seen. And I've been in a bunch.
Thank you.
Yeah, we appreciate that.
Please share. Lena is raising her hand.
Take care, be safe. Text me when you get where you're going.
Thank you, Kirby. Lena, did you have a comment or a question?
Just seeking some clarification, Madam Chair. And so was the motion to proceed in authorizing the CEO to negotiate the contract? Was that the intent?
Bring it back.
I think the intent was to move forward and
Yeah.
still bring us the
Yeah.
final contract. for
Yes.
approval.
Okay.
Move forward.
Pursue the contract, I guess.
Okay,
Is that
perfect.
correct? Is that the clarification you need?
That is, yes, thank you.
Okay.
I have reviewed the contract and made a couple of proposed revisions, but haven't had the opportunity to speak with Mr. Walk about it yet. So we'll get there.
Perfect. We'll look forward
Thanks,
to it
Lena.
next month. Okay, thank you, Kirby. Thank you. Thanks for
Well
being
done.
here tonight. All right, we need to go back to item D, the transfer from the construction account. Everyone should have the resolution as it needs to read in your email. So, given that resolution, would board like to take action on this transfer? I wish that I could give you a current balance. That's the only information that I don't have, but, yeah. I have a guess, but I don't, have an exact balance amount. Michelle knows that, so.
Okay, so we're authorizing the
Try to get
transfer of 500. Cause I was trying to remember, I know Michelle was keeping tabs on how much the construction account still owed the district account
With nothing, we've reimbursed the district in full.
in full at this
What
point.
is left is ours reimbursed monies. And I want to say it's about 1.3.
That's the number
Is
that
that-
Michelle told me.
Okay,
I don't
okay,
have the-
so-
More than 1.2.
thank you.
Is there a reason why we're still keeping 700 or 800,000 in that account then?
I think just to make sure that all of our closing costs are finalized and that everything is
Okay.
done. So
So maybe in another month we
we can transfer it all, yeah.
Okay.
Distinct.
offset some interest potentially, maybe,
Exactly.
or do something
Exactly.
else beneficial for us.
Yes, I think we're
Opposed to
just
sitting there.
on making sure that everything, all of our
That's fair.
i's are dotted and our t's are crossed. That's my understanding.
Madam Chair, I would make a motion to approve resolution number 11-2026.
Okay, thank you, Ashley. We have a motion and a second and a second. Any further questions or concerns? Okay, all in favor of the motion to approve resolution 11-2026, please signify by saying aye. 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 Motion carries. Okay, next item on the agenda is National Rural Health Association Opportunity, item H. So Rex, do you want to give it on that?
Oh, yeah, okay. Well, when we were on one of our,
We might need a brief recess.
yeah, those cookies were looking pretty good too.
Okay, my stomach's growling. 5-minute recess.
Oh, I only need 5.
Well, let's take 10.
That'd be good.
That gives everybody a little opportunity. We'll reconvene at 8:52. Okay? There's something the same thing, isn't it? Well, we'll turn our mic back on and it's too. Yeah. Okay, we are going to reconvene a little early here, but we're all ready to go. So now I will turn the time over for item H to Rex on the National Road Health Association opportunity.
Well, this actually came up on the call you and I were on 3 weeks ago. And they mentioned that the USDA in the Washington office had mentioned they had this program for certain hospitals where they would assist with financial strategic planning and doing other things, looking at your financials, how to strategically solve them going forward, recruitment, retention, just basic things for a successful small rural hospital. So after the call, we reached down and visited with them and then it's my understanding it became part of the arrangement we signed up for. So the deliverables at the end, I can't read it either, so whatever. But at the end, the goals of this program are to improve the financial position, increase operating efficiencies, which would be helpful because we could use some benchmarking. I know health tech has some. Implementing quality improvements, evidence-based health outcomes, addressing workforce recruitment and retention issues, focus on some telehealth, working on delivery systems, resolving gaps and duplications. And then the board can get certified through the National Rural Health Association certification program. So this is at no cost to us. USDA is picking up the tab. The woman that's in charge of it at the National Rural Health Association in Kansas City is a gentleman by the name of Brock Slovak, good guy. And I would like to have the letter a little earlier, but good guy. But there's 4 options that the board would need to consider or the 4 options that are provided to us through this program. And, now it's not so much, do we want to do it? We need to do it. It's more choosing who we do it with. But the options are Whitley, which is a accounting firm up in the north, Michigan, Minnesota areas, I think, North Dakota, more in the north part of the United States. Forbes, Mazar is used to be BKD. So, they obviously, have great footings in accounting. Bailey, who we've used before and certainly are continuing to do things for us, and then Stroudwater. And I don't know what the board's experience was with Stroudwater. I've had really good experiences with them in the past. I know if Brock were here tonight or on the phone, he would say that would be, he's hesitant to give his preference, but he knows Stroudwater's working with Teton Valley on a project as well. And we would get their best person working both for us and for them. But we would have those options to decide. And if, again, this doesn't have to be decided tonight unless we do want to move forward with Stroudwater, because that's time to another engagement in the region. So for you, I think for it to be, at least he said it would be 2.5 hours for the board chairman. There would be about an hour's worth of board training to get started. And then we would be feeding information back and forth. And then they would be on site, I think 3 or 4 times, I think, gathering data and providing recommendations for us that would be actionable recommendations. We did a similar program when I was in Kansas. It was with Texas A&M, and they had gotten a large grant with the federal government, and they came in. There were 3 hospitals, I think, and we submitted a grant request. And I didn't think we'd get it. I was surprised we did. But they were with us for 3 years, and that's sort of how we went from where we were to being a top 20 critical access hospital. Just a lot of things we could have never afforded on our own. We didn't have a management agreement. Certainly we have, health tech here that can provide that. But I think all this works in concert to help us get to where we want to get to. And obviously we've signed up for it already. We just need to know who we want to dance with. So.
And it's all at no cost to us.
No cost, yeah. And obviously USDA is trying to protect their investment and making sure we're financially viable. But the fact that the National Rural Health Association is involved and Brock Slovak's involved is takes a lot of any guesswork out from me. I know it'll be done really well. And if it's not, or we have issues, if we've had issues with these folks in the past, Brock will definitely get involved and make sure it meets our expectations. So.
We have had some issues with Stroud Water, and some a relationship with Stroud Water, but it was clouded by the fact that we had to pay those services, I think, so this would be in a different capacity.
Was it more related to was it
Security funding?
funding? Yeah, I don't know what they're, but I know when it comes to operations in small rural hospitals, these guys are probably the best. I mean, they have really, really good consultants, so I don't know if that was sort of out of their sweet spot, but from an operational financial improvement standpoint, Stroud, I mean, they're all good. I mean, but Stroudwater probably would have the edge.
Yeah, we do have a relationship with them going way back,
Right.
but I daily as well. So I guess I would be comfortable with any recommendation you would make, Rex. And
Well, I mean, I've always been an Ide Bailey fan, and I was somewhat disappointed we moved away from them. I mean, I know there were issues with delivering, getting an audit done, but I would have hoped we could have gotten that fixed. They bought Sion Johnson, who was a leader in rural healthcare accounting, probably the best. So, I mean, they're obviously really, really good too. So it just, Brock suggested Stroudwater because they're here and he knew who we'd be getting on our account, and he thought there'd be some advantages working with Teton Valley since they could combine things when they were here.
sure. I did some work with Brock early on too, and I trust his recommendation,
I
but
mean, that's sort of,
just yours as well. So,
yeah, I mean, there's kind of I mean, I've worked with BKD before, and I mean, they've changed since they were bought out. I've never worked with Lee, always wanted to, but I think this is a project where you kind of go with, here's a horse you're familiar with.
sure.
So, but definitely that was, Brock can't give us his, his preference, but I think reading between the lines and kind of, how you structuring this, that would be his preference. And we would just have to make sure it met expectations this time.
Sure. I would totally defer that decision to you unless you guys.
The only thing about Ide Bailey, I mean, we're already doing stuff with them on the rural health clinics. I don't, it seems like they need to focus on that, and I'm afraid we would get the same person doing both, and then things get diluted a little bit, but I mean, I don't know that, just a feeling. I'm comfortable with Stroudwater if you want to give them another chance. And I know Brock will make sure it meets our expectations.
I'm comfortable with that. Absolutely.
Okay, well, he wanted to know, he just texted me just right before we went on, so I know they're anxious to know, and I said, well, that's surprisingly, it's next thing on the agenda, so. Okay, we'll move forward.
I definitely
Hold it,
I
sorry.
definitely have a difference of opinion with regards to Stroudwater, with regards to specifically their financials, financial oversight, but that's just my comments. But obviously, I think that you've looked into this and you have experience with it, Rex, so completely in favor of your proposal.
I'll do my best not to disappoint, but again, I've got Brock Slobach behind us, and I know he won't let them disappoint us, so.
Yep, completely confident with your decision.
Well, thanks, and I get where you're coming from too, I think, so.
Okay.
Thanks so much.
Okay. Are you ready to discuss the AccuRecovery program?
Noah, are you still on? And Tricia?
I think we're here.
Oh, man, you hung us out there for a little bit, Noah.
Apologies, I'm actually out on the walk with the dog. So you're catching me in the park.
Well, I told you it'd be about 7:15 at the latest.
Yeah, that's what I told him.
That's on me.
Rex,
You
I'm not
guys
known
enjoy
for
it,
being
start?
punctual, so this worked out great.
Okay, well, you're on. This is your moment.
All right. Well, thank you so much to the board for giving us just a few minutes. It's always so great to see you, and to Rex and admin for just getting us on the agenda. We'll keep this very brief. I think most people here have seen me speak at least once or seen me in the clinic. I'm Noah Schutz. I'm one of the physician assistants that is in the ER and also working the addiction medicine clinic, which, by the way, we are filled up on our 2 slots now. So we're actually looking at opening up more time. So we really appreciate the board's support of that program. And a shout out to Penny Jensen. She's an incredible substance use navigator. And this spins off of that. And it's a really nice segue from hearing about the mental health services that you all are considering for seniors, because I think it just shows that Sublette County is really starting to explore some evidence-informed, very helpful, and kind of interesting treatments that most places don't have, especially rural America. And I'm here with Trisha Scott. She's been my mentor through this program, and I'll just give a quick blurb on what we're looking at. And the idea of this really, for the board members, is just a quick teaser on a project that we're working on, that we wanted to keep you apprised of, because we're really hoping that a collaborative framework with the hospital district can really start to offer some incredible free services to Sublette County residents. So in brief, AccuRecovery Wyoming is an acupuncture treatment, an ear acupuncture treatment. Some of you might have seen our proposals for visitors and volunteers to come in during a training. It's a treatment protocol that has been used since the 70s. It started out for addiction medicine, and we can go in that history at some other point. But we've started noticing that it is a treatment that provides a lot of benefits to a huge range of people, not just folks dealing with substance use, but chronic pain, behavioral health concerns, anxiety, depression, insomnia. It's been used for treatment of PTSD, especially with first responders. A really cool study from the 9/11 attacks. And the program that we're bringing to Sublette County, well, it's been here. Trisha can speak to that, but we just had a 3-day training put on by AccuRecovery Wyoming. It's a licensed nonprofit based out of Laramie. And we had the Opiate Settlement Fund pay for this treatment, this training of 4 Sublette County residents to become ear acupuncture practitioners. And our goal right now is to really expand this service as a free health treatment to Sublette County residents. Currently, it's being offered once a week by Trisha at Public Health, and I'll let her speak to that a little bit more. But our goal is to really open this access up to everybody that we think can benefit from it. And the goal for it is to be free. Our idea is, as AccuRecovery practitioners, to partner with the hospital in some form, and we're talking with Rex and Lena about how that would work. But we're really hoping to use the space and the name of the Sublette County Hospital District as a way to really institutionalize this new treatment service that we're going to be offering to town. We're looking at maybe, I'm getting chewed by mosquitoes if you guys can see me swatting. It's that time of year, I guess. But really what we're hoping for is, all of us are going through supervised trainings right now. I've completed mine with the help of Trisha, and I've submitted my application to be certified. And we're hoping to have 1 to 2 sessions per week that we offer to the community for free. And I think what we're going to be doing is advertising it or branding it as a like a stress reduction, stress relief free community clinic. We're not going to gear it towards any certain population, but it's going to be something that I'm going to encourage my substance use treatment program patients to go to. We want our mental health and behavioral health patients. We want our seniors. We'd love anybody from EMS and first responders. Something that's just novel. We don't see it a lot in rural Western Wyoming. And we think it could be a really cool program that both our small nonprofit and the hospital district can partner with. That is basically what we're looking at. Really, the only ask too is for support in the community, and to tell your friends and family about what we're doing. We'd be happy to promote and provide more information on what this looks like. We'd love to offer everybody on the board a treatment to get an experience. If Rex got it during our training, so he can speak to it directly, and then at some point we're looking at how it might work to use space up either at the hospital or at the Sublette Center, and build that out as we go. before I take questions, I'll just pass it over to Trisha Scott, so she can introduce herself, give some background on how she's been carrying the torch here in Sublette County for the past 10 years, and then also talk about some of the more the professional components of AccuRecovery and what our licensure actually looks like.
Thank you, Noah. Hi, Tricia.
Hi, Tanya. Madam Chairman and the board, thanks for giving us this opportunity to speak, I hope, really briefly about where we are right now and where we might like to go. As Noah said, AccuRecovery Wyoming is a state organization. I'm on the board. We've been in existence, I think, since 2018, I want to say. AccuRecovery providers are licensed by the State Board of Acupuncture, and the State Board of Acupuncture accepts the AccuRecovery Wyoming training curriculum. So the 4 people in Sublette who trained 3 weeks ago all will become licensed, state licensed auricular acupuncturists. What else do I want to talk about? I just wanted you guys to know that it's a legitimate organization, even though it probably feels a little fringy. I started doing this 10 years ago in Sublette County on the advice of Dr. Strockland. I don't know if any of you remember Dr. Becca Strockland when she was here, but she's the person who told me about this back when I was working at High Country Behavioral Health. And I was riveted. I mean, like Noah, when you hear about this and you go, what? In 3 days, I can train to do something that has all this benefit that, you know, a full body acupuncturist does a 4-year training, where this training is a 3-day training. And a lot of counselors, psychiatrists, people in Noah's position, all kinds of many people, a wide variety of backgrounds can do this training and then learn to provide the clinics. We do the AccuRecovery model, AccuRecovery Wyoming model takes the 50 years of practice that exists in the U.S. It's a model for free. It's to be offered free. So I do this. I volunteer to do this because I'm interested. I'm really rabidly interested in it. I'm interested in it because it's free. I'm interested in it because it's nonverbal. I'm interested in it because I see the benefits right away when people receive those 5 needles in each ear, and you can just see them start to visibly relax. Maybe Rex can talk to that for a moment. And I'm interested to see if you have any questions.
Thank you, Tricia. I am kind of intrigued. I love when Eastern and Western medicine intersect. I think that's kind of cool. So
you could have really used it about a month ago.
for a long time. I guess I'm just wondering, it'll be off-site, if I'm understanding correctly for now, but eventually the hope is to do it on-site. I mean, when I say on-site, I mean on hospital property. Am I understanding that correctly?
Go ahead, Noah.
That would be the goal, Madam Chair, is to utilize some of the hospital space to offer these services to the entire community for free.
Okay. And so given that, my only question just as a board member would be, are we covered through the credentialing process and through malpractice insurance and all that for this sort of treatment modality?
We're working with all of those, through all those logistics right now with Rex and Lena. Some of those questions are coming up and we're kind of in the works. We think that we can absolutely get this all lined up, and we'd love to come back to the board or have, Rex and Lena discuss it separately once it's all lined up, so that you all are comfortable with what we're doing. But that is the goal, is to get all of that covered so that there's no other questions about liability, malpractice insurance, and things like that. It would literally, what we're looking at is it would mostly be an AccuRecovery Wyoming treatment offered by licensed practitioners from Wyoming Recovery in collaboration with the Sublette County Hospital. That's kind of what we're thinking, but that's to be hashed out.
Okay, thank you, Noah. It sounds like a great program if we can work out the details.
My only other question is if we're offering it for free, how much is it costing the district, I guess? Or does it?
That's such a good question. Right now, the Cassie Crumpton, who is administering the Sublette County opiate settlement funds with the opiate settlement fund board. Did I get that right, Noah?
Yep, that's it.
Yeah. She is willing to consider, or she would ask us to consider asking the opiate settlement fund to pay or to fund the supplies. And needles are very, very, very inexpensive. So there's really, we call this a low to no cost treatment, a low to no cost non-pharmacological treatment. It would cost the hospital nothing in terms of supplies. And Lena and Rex are the ones who are going to be talking about with Noah how that might look with hospital providers.
Okay.
Does that answer that?
Yes, good enough
Yeah.
for now. Thank you.
Yeah.
You have questions? Yeah,
I'm intrigued. I was wondering too. So.
Okay. Okay. All right. And this is something that you're recommending
Yeah,
that
well,
we,
we're gonna do more research and we
Yeah.
had a call or two and then we'll bring it back, so.
okay, cool. I think it sounds like a great.
It's
community
I know I'm
service.
gonna go Google it after our meeting.
We can talk after.
I'll volunteer.
What it does to you.
Give me a treatment.
That could be.
Or education next time.
Thank you, guys. We appreciate it.
Thank you for your time.
Yeah, sorry
Thank
to
you,
have
everybody.
kept you waiting for so long. Sorry it's so late.
No, I hope you guys get to finish before the sun's completely down. Have a great night.
Thanks, guys.
Too late for that.
Okay, that leads us to org chart revisions. That's.
I'd just like to commend Kimberly, and you. This is not easy because we don't have a software program to do it. So this is pretty manual and I did mess it up a little bit, putting Carrie over to me, and that I know Jan likes straight lines, so that messed the line up. Anyway. But Carrie, we met earlier and she definitely wanted a line to me, so I put her in there. But basically, I mean, should reflect pretty accurately the reporting requirements, including health tech, how they report up to the board, Lena, Jan, kind of a dual responsibility. The only really change is I took on 3 different people reporting to me where they had.
One material management coordinator, it's at the bottom.
Down over here on the side.
Yeah.
So I took on Mike as we're doing the distribution, Mike Straws, we're doing the primary distribution arrangement, at least for the summer. Christie, a suggestion of health tech being risk management and quality, that probably wasn't ideal to be run through the nursing department. And then somebody else.
Medical staff coordinator.
What's that? Oh, the
Medical staff coordinator.
And the medical staff coordinator, that'd be Danny, and that was another suggestion from health tech. So those are the people reporting to me that weren't when I started here. And then we also put Christy Bartlett up as the compliance officer because she needed a direct line to the board. So
is this different? Or is the one that I'm seeing different than what?
I uploaded that, but then he added Carrie's line, the crooked line right there. Yeah.
Okay, sorry.
Because we just needed a line from Carrie to the CEO. So, yeah.
I think that's critical.
But other than that, it's
In terms
exactly the
of
same
Foundation director, but she's still under.
under the foundation board of directors. Yeah. So like she.
Okay, because she's still under Rex as the marketing public relations director though. On her side.
Yes.
I mean, in theory, we should probably drop the box a bit, but this is supposed to be get done before board meeting. But it should probably be a little bit, drop down a little bit, I think. But really, we just want to I have 3 different people reporting to me than I did when I started here, and 2 of them are recommended from health tech, which I think make total sense, and the other one is maybe permanent, but may not be, we just need to get through the distribution piece and I can help with that since that's the world I came from, so.
Okay, so you're not looking for an approval of a new org chart, you're just giving us information.
Just this
that's changed
information.
temporarily.
Well, I think going forward, we need one for all of our new employee orientations to have something to show people this is how it all supposed to work, so.
Sure,
And if we have major changes, we'll bring it back to you. This is information.
okay, okay. Anybody have questions? Hey.
Well done.
All right. I don't believe we have any FOIA requests, which is the last item under new business that we need to address, so. With that, I would suggest that we enter into executive session for personnel, contracts, and legal. I don't believe we have any real estate issues tonight that we need to discuss, so if someone could make a motion to that, and we can carry on with that.
Madam Chair, make a motion that we go into executive session for the purposes of personnel, contracts, and legal.
Okay. Okay, motion and a second. All those in favor, please say aye.
Aye.
Aye. That's okay. Motion carries. All right. We'll do a brief executive session. We will have to come back and address the one new business topic for the board vacancy. We'll do that after executive. So. Sure.
If you're okay.
Anymore.